Sounds to me like we've come a long way in review courses. Gosh, dinner at Dave & Buster's, drink coupons. That's unbelievable. It almost makes it worth being resident again. Almost, not quite, but almost. How about them Spurs? You Dallas guys can stay. That's okay. Since we won, that's all right. Now, I just have one comment I had to make while people are filing in. I saw the paper this morning. I couldn't believe this LeBron guy. Did you read that? He hasn't even finished high school yet. Didn't have a diploma yet. He's worth $100 million. He signed this Nike. We signed a contract with Nike. It's going to be $75 million some, and another thing with some card company, and it's just unbelievable. And I would think that probably the average person here has, what, 13 years out of high school? If we pooled all our assets, every single one, we wouldn't even be a fraction of $100 billion. There's something's wrong with this world, let me tell you. Okay, we got a lot of stuff to cover. I know it's rough in the afternoon. I know you're tired. You got something to look forward to. But I'll try to make this as interesting and educational as possible. I have two things I have to cover or comment on. A bunch of people asked me questions last night, which is great. I'm glad to talk about whatever you want to talk about. Somewhere in my seizure yesterday, I must have said sometime that treatment for soft tissue sarcomas was chemo and surgery. If I said that, you should have thrown something at me. Remember, soft tissue sarcomas is generally radiation and surgery. Bone sarcomas is typically chemo and surgery. So if I say something abnormal, remember, it goes on Miller's evaluation form. Just remember that. Second question was, the radiofrequency ablation is the treatment of choice. However, if osteoid osteoma is in the spine and apart from maybe the posterior element or an pedicle or something where it's away from the dura, if something's close to the dura, I wouldn't pick radiofrequency ablation because you don't want the guy to wake up and not have all his faculties, so to speak, with him. So something near the spine that would be at risk clearly would be an open treatment rather than RF ablation. Okay, chondroblastomas. Now on to more cartilage tumors. Chondroblastomas is one that shows up pretty commonly on the test. This is an epiphyseal lesion of young people. It can cross the physis into the metaphysis. Most of these are skeletally mature patients. Mencken used to call it a bar mitzvah present, the 13-year-old with an epiphyseal lesion. That was a chondroblastoma. These are painful, and a good portion of them around the knee, about 30% around the knee. The other place we see them is proximal humerus and the proximal femur. And here's an example of a proximal tibia one. Notice it's crossed the physis. These things, much like giant cell tumors in the skeletally mature, but the subchondral area of bone, and can even break into the joint. And here's one in the calcaneus. And believe it or not, this is another common location. This is known as a Codman's tumor when it shows in the calcaneus. It's the same tumor histologically, just one place it shows up. Maybe because of the apophysis that's there. Here's one around the hip, geographic, lytic, okay, and you can see here on the CT scan the density of the mass inside. It's sort of broken out on the interior wall. Typically, these are lytic lesions, often with a sclerotic rim. You may see mineralization. That's what they classically talk about in textbooks, but it's not that common in my experience. And histologically, you see chondroblasts, giant cells, loose myxoid tissue, and the buzzwords. Remember, we already buzzword the fibrous dysplasia, which was the ground glass, which I couldn't remember, my seizure. Chicken wire calcification is the buzzword for this one. Chicken wire calcification or the cobblestone appearance. Sometimes these things are subtle. Sometimes it requires additional imaging, and you see there's something going on here, but an MR scan clearly lets you see this epiphyseal lesion. Now, while we're talking about epiphyseal lesions, remember, what is the most common epiphyseal lesion, all comers, in kids? It would be infection. I heard it outside somewhere. That's right. Infection is far more common in a child, in a young person, than chondroblastoma. Here's another example of a proximal humeral lesion, sort of multiloculated. You can see it's got a little sclerosis around it on the CT scan. Distal femur, eccentric. Again, some sclerosis seen on the MRI. Here's one that was sent to me that I treated a number of years ago. This poor kid had been hobbling around with people telling me he had a knee sprain. And finally, look how big this thing is, all the way down the metaphysis of the tibia. And on MRI, you can see this all the way down here and has destroyed essentially the subchondral bone. And we ended up having to put an osteoarticular allograft on this. Now, I saw him back sometime later. Here's 5 years post-op. I can't tell you that's perfect, but it beats not having a tibia bone there. So it's done relatively well, all things considered. So what's the treatment? Just like all the other aggressive benign lesions. Meticulous curettage and bone grafting, so-called extended intralesional curettage. Recurrence, just like giant cell tumor, and ABC is reported up to 30%, but I don't believe it if it's adequately done, the treatment, the curettage that is. Most of the time, we do a local adjuvant treatment with these. My choice is phenol. We talked about cryotherapy and all yesterday. And remember, this is one you need to put a red star next to. 2 to 5% of these things will metastasize to the lungs. So this is one of the so-called benign lesions that has metastability. What's the other one commonly you get asked on your board exam? Giant cell. You all know that. Perfect. Perfect. Here's a case of a gal that I treated a number of years ago, proximal humeral lesion. You can see it right here. Here's it exposed, the articular surface of what's left. This thing had eroded completely into the joint. Here's an osteoarticular segment. And here, 8 years later, this gal showed up in my clinic under a different name. She was now married, had joined the Air Force, and was sent to me back to see me because she was having problems doing push-ups and pull-ups. And I said, this girl's killing me. I said, no, you're not in the military. You're out of here. And this is a little flattening here, but it's, once again, better than a big old hole in your humerus after 8 years. This is what you see histologically, okay? You see some giant cells in there, and then here's the so-called chicken wire calcification. You see around these cells, this area sort of looks like chicken wire where the mouse is moving. That's classic. And the cobblestoning is the pink cytoplasm sort of pushed up against each other to look like cobblestones. So the chicken wire calcification would be sort of the rim around these things, and the cobblestoning are these plump, sort of epithelioid appearing cells pushed together. This is a classic appearance. This is the ant. You need to remember, and you're likely to see one of these. Okay, CMFs. These are relatively rare, second and third decades. Once again, Pfemmer's law, many of them around the knee. Typically, however, in the proximal tibia and in the feet. So if you see one in a test, it's going to be a proximal tibial lesion or a foot lesion. Pain is common, often long-standing, and they're lytic eccentric. That's a pretty good key. Eccentric lesions that are pretty well sharply demarcated from the bone, typically not mineralized. So here's a proximal tibial lesion, eccentric, but this is not an NOF because it's not a nice sclerotic margin, and it's pretty good size. While an NOF can be eccentric like this, and it can look like it's got some loss of bone, it's not going to be this aggressive in appearance. Here's a couple file cases, proximal tibia in the foot. See, it's eccentric. Histologically, you get loose myxoid areas with stellate-appearing cells, which is what I think makes it the easiest to recognize. Some fibrous tissue, some spindle cells, and some giant cells. And the treatment, like everything else, curettage and grafting. So extended intralesional curettage on these things. Recurrence rate about the same with all these things. Now the data that we use is all this compiled data over the years. I dare say that if we took recurrence data on these active lesions over the last 5 years or so, and nobody has that compiled, but if we did, I think probably the recurrence rate would be far lower, more like 5 or 8%. But the board answer is still right around 20 or 30% for these active lesions, okay? Because that's what our literature still says. And here's what you see. This is a classic appearance. These are these stellate appearing cells here. See, they look kind of like little three-winged frisbees or whatever. I don't know. And there's this myxoid area, and you have giant cells and fibrous cells. So this, again, is a ant mini. The CMF has this appearance. And typically what you're going to be shown on a question is a photomike that has this kind of tissue in it, the myxoid with the stellate appearing cells with some giant cells around it, and maybe some fibrous tissue. Here's another example. Myxoid. Here's these myxoid area with these stellate cells. Okay? And this has sort of that chondromyxoid appearance to it. Now, you absolutely are going to see a chondrosarcoma because this is the number 2. Remember, number 1 big guy was osteosarcoma. Number 2 now of primary sarcoma of bone is chondrosarcoma. Pelvis 25%, ribs 20%, and so on and so forth. Most people are over the age of 50, and pain is clearly the presenting symptom, like with any other bad problem, severe at rest and severe at night. And so this is a kind of thing you'll see, sort of mixed lytic blastic lesion. This one seems to have sort of a mineralized appearance to it. On MR here on this T2 image, it's very wet and extends way down the canal, so it's pretty good size. But on cross-sectional imaging, you see on the CT scan, there's clearly a big soft tissue mass with some mineralization in the back. And on the MR, you see the same thing, a big soft tissue mass sticking out of the back. So that's not benign. Something's in the bone and crawling out of the bone is not a benign thing. It's malignant. Radiographs typically show destructive lesion with some mineralization, reactive cortical changes, maybe a soft tissue extension if it's a high-grade aggressive one. But you have to correlate the radiographic, the clinical, and the histologic features to make the diagnosis. Because once again, if you dig something out of the hand and you throw it to your pathologist, they say, oh yeah, it's pretty cellular. And you tell him, well, it's from the hand. He'll probably say, okay, well, it could be an enchondroma. If you dig that same material out of a distal femur and send it to him, he'll say it's pretty cellular. And you tell him it's a distal femur, he'll say, well, it could be a low-grade chondrosarcoma. So it's very important that you talk with your pathologist. I know that's sometimes painful, but they actually do know how to talk, typically. Here's another one. Periacetabular area. Remember when I told you about the periacetabular area? Sort of the chondroid-like? Here's another one. Destructive lesion here. Clearly on the plain film, there's something going on. You can see on this MRI, on this coronal image, T1, there's all the signar abnormality here. And on cross-sectional imaging, on the CT scan, there's some density out here that doesn't belong there, and signar abnormality. So here's one side versus the other. Again, chondrosarcoma. Here's a case that was referred to me many years ago with a gal whose only complaint was she couldn't bend her knee all the way, and she had some soreness behind her knee. And all there was this little lip of bone here, only abnormality radiographically. And this person had a CT scan as well, and they said, oh, well, you've got a little irritation down there. Well, very interestingly enough, if you get some other imaging modalities, you can see there's something that's inside the bone that's wet on that T2 and crawling outside the bone. And indeed, that little shelf of bone you're seeing is reactive right here, but what it's reacting to is reacting to tumor that's crawling outside the bone. So this is another example of a chondrosarcoma. Here's a patient that was referred to me just recently. I didn't operate on him yet, but I can already tell you what it is. He just came to my clinic, I think, Monday or maybe last Friday. Nothing much on radiograph that's here, but look at his bone scan. Very hot, and here's T1, T2, and GAD image. Long, he has a dull ache there that's persistent all the time, and this is a classic appearance of an intramedullary chondrosarcoma, probably a low-grade one. So on T2, it's very, remember, edematous on T2. On gadolinium, there's hyperemia there, but notice that there's not blood flow into the entire thing, which is consistent with chondroid tissue. So that's that mixed appearance that they have. Histologically, you see increased cellularity, multinucleated cells, enlarged cartilage cells, and remember, you got to tell the pathologist where it's coming from, because a periosteochondroma and enchondroma is pretty cellular also. Fortunately, most lesions are low to intermediate grade. That's another question, guys. Remember, most of them present as stage 1A, but there's lots of overlap between low grade and the benign lesions, and so it's kind of important that we figure out where they're coming from and what the symptomatology is. Remember, I told you yesterday, this is a low back pain for tumor surgeons. We hate chondral lesions because they're so hard to figure out. Here's one with mineralization diffusely in the distal femur. When there's this much going on, you worry that there's something there. And here, we all recognize this is chondroid tissue, but it's fairly cellular. Lots of cellularity, active chondroid tissue you see on these pictures here. And then, in particular, notice that here's bone, and this chondroid tissue is pushing itself through the interstices of this bone. Chondroid tissue and enchondromas are lobule blue balls. Chondrosarcomas push through the tissue and are destructive, and so they appear differently. If you're shown a radiograph with something that's even modestly aggressive looking, but you see this cellular chondroid tissue in the interstices of bone, that's a chondrosarcoma. That's what the author is trying to show you. Here's another example, fairly cellular and multinucleated lacunae. Lesions of the axial and proximal skeleton have a more aggressive course. That's a clinical fact. We don't know why. Is it a temperature difference? Maybe. Or is it because they're discovered later? Probably, because they get to be bigger and they're more difficult to treat. Treatment for these things is wide surgical excision. They are, by and large, chemo and radiation resistant. Although I have to tell you that Herman Soot, who is some people consider the father of radiation oncology at MGH, says, Ted, there's nothing that's radiation insensitive. You know, you have this vision of this crispy fried arm, you know. And I guess that's true, you know. So, but by and large, the treatment for chondrosarcomas, for chondroid lesions, is surgical removal, because we don't give them chemo and we don't give them radiation. Notice I put extended intralesional curettage in selected cases. That one case I showed you with a tibial lesion that's kind of crawling down along there, but you don't see radiographically, I'm anticipating that to be a low-grade chondroid lesion, probably, you know, grade 1/2 or even grade 1 chondrosarc. And in those, there's been a big push in the Musculoskeletal Tumor Society in the last few years to open them, scrape them, burn them, so here's that same extended intralesional thing, and then phenolize them, and then bone graft, and put the bone window you took back on there, and then hope that it's not a problem for you. In years past, when I first started practice, we'd whack people, you know, tibia out. Okay, sir, you're going to have an intramedullary, or excuse me, an intercalary allograft reconstruction. And people would go, ah, and flee out of your office. You never see them again. Now, if you tell them you're going to scrape it out, you know, they're pretty reasonable with that. And it seems like most people do pretty well with that. But there's a little bit of risk, certainly. Here's an aggressive one in the proximal femur. And this one's treated by allograft and composite reconstruction. Here's one I did last year in a young basic with a spine, the spine of the scapula. And notice on T2, it's got that lobular, it's edematous. On T1, it's hyperemic around the periphery and a little bit, but mostly dark because there's not a lot of blood flow into these chondroid lesions. Another example in the distal femur. Here it is, something in the bone, crawling out of the bone. It's bright on T2. It's hot on bone scan. It's an intramedullary chondrosarcoma that's trying to become extramedullary at the same time. And here's a 5-month post-op film that I had in my file somewhere. Okay, so it's important to recognize in chondrosarcs that histologic grade correlates with metastases. And histologic grade, once again, I said it yesterday, I'll say it again, histologic grade is the most important determinant on survival and prognosis. So for chondrosarcs in particular, these low-grade lesions have a 0 to 5% metastatic rate, which is why we think it's okay to scrape them out, provided you do something, you know, adjuvant treatment with them. Grade 2, which is a little bit higher, of course, is about 20%. Grade 3, 60%. And then the very feared dedifferentiated chondrosarcoma, which has about an 85% met rate. And both people always do badly. They're very difficult to treat. Speaking of the devil, dedifferentiated chondrosarcoma. This has been on the test on and off for the last few years because there's been a resurgence of interest in it. But I'm going to tell you the clue to figuring it out is looking for a chondroid lesion that's got some bad stuff about it. It's almost like looking for pagetic sarcoma, pagetic bone with something bad going near it. And then they're going to show you a photomic like this with chondroid tissue here and spindle cell around it. I guarantee you that's what you're going to see. And you'll look at it and you go, yes, and you move on to the next question. Radiographically, the appearance of a dedifferentiated chondrosarc is similar to chondrosarc, but as I mentioned, widely destructive region. A lot of them have pathologic fractures because they're just very aggressive tumors. And once again, pain is a very common feature. Often, they have long-term pain from their underlying chondroid problem, and then suddenly an episode of severe pain, either from the pathologic fracture or from the aggressive change. Here's some file pictures of a lesion with lots of mineralization. Here's one, a mineral lesion with destruction going on here. Here's another case, definitely chondroid in there, but clear destruction and changes around the periphery. And here's what you see, chondroid, and there's high-grade spindle around it. So this is the kind of picture you're going to be shown to make this diagnosis. Most of them are in the femur and the pelvis. Histologically, they're typical chondrosarc with high-grade spindle sarcoma around them. And the treatment is like any other bone sarcoma. Chemo, resection, chemo, and guess what? Everybody dies anyway. So it's a really hard thing to treat. 13% survival at 5 years. This is another one of those, take a fishing pole and have a good life. Recently, the MDR gene, multi-drug resistant gene, has been identified in neoplastic cartilage. Remember that P glycoprotein pump I mentioned yesterday that spits out the tumor stuff? Spits out chemotherapy, which is probably why these things aren't chemo sensitive. And as I mentioned already, if you're shown on your test now a low-grade lesion, they tell you it's low-grade chondrosarc, or it looks like a low-grade chondrosarc, your answer, I still think, in a long bone is intralesional curettage with adjuvant therapy, like I talked about. I think that's the right answer, and I'm pretty certain that's the way that we're all going these days. It may not come to that. They may not split that hair. But if you see that, that's, I think, your answer. Okay, let's see. Fibrous lesions of bone. We're going to talk about NOFs, desmoplastic fibromas, and fibrosarcomas. So first of all is a metaphyseal fibrous defect, or so-called NOFs. These are ones that are commonly recognized by orthopedists, fortunately, but not very well recognized by anybody else. And they'll say, oh my gosh, Johnny's got a tumor, and they'll send it to you, and that's when you just smile and say, Johnny's fine, that'll be $50. So we love these ones because they're really easy to deal with. Most of these resolve spontaneously. It's probably not a true neoplasm, and often will leave dense bone as it heals. Sometimes it leaves a giant bone island. The most common places are distal femur, proximal tibia, distal tibia, and they're much less common in the upper extremity, although I have seen some in the upper extremity. And here's a common appearance. It's a well-demarcated eccentric. This one's already in the process of healing. See, it's already healing up here. Sort of lobular appearance. They can slightly expand the cortex. On the lateral view, you see that. It's geographic. This one's easily a logic 1B, maybe even 1A in these areas, obviously. And here it is, the nice clean mirror over here, eccentric. Still a little bit bright on T2, and some flow on GAD. Most lesions are asymptomatic and discovered serendipitously. Lytic eccentric lesion with sclerotic border, bubbly appearance, and as I say, the cortex is frequently thinned and maybe slightly expanded. That's not uncommon at all. Here's a large one in a child in a distal femur, and here's one in a tibia with pathologic fracture suffered from minor trauma. So when they fracture, you got to treat them. If it's a severe fracture, treat it just like any other fracture. But if you're going to be there open, it's probably worth taking these things and scraping them out. But it's a wives' tale that sometimes people have been taught in the residencies that the pathologic fracture is going to make this thing go away. No. Pathologic fracture, the fracture will heal, but this thing will persist. It takes a while to go away. If you think someone's at risk for pathologic fracture or they're real symptomatic, then you may want to just scrape it out in advance. Here's another example of a distal tibial lesion. This is clearly a logic 1A geographic, nice sclerotic around here. Here's an eccentric one in the proximal tibia with not a lot of cortex seen on the side, and sectional anatomy, that's what I'm trying to say, sorry, would show you very thin cortex, and sometimes even no cortex there because of the fibrous tissue. Another distal femur, not very hot on bone scan. CT scan here, this common appearance, you see sclerosis around it, and here this one was curettage because this person was symptomatic and had pain with activity. Histologically, what do you see? You see fibroblastic spindle cells in whorled bundles, giant cells and hemosiderin. Now, I don't want to confuse you, but in my opinion, non-ossifying fibromas, NOS, metaphyseal fibro defects, same difference, have the storiform pattern. I know you're going to seize on me because everybody told you storiform means MFH. Well, that's true, but this whirling pattern in the fibrous tissue of non-ossifying fibroma is pretty common. Giant cells and whirling fibrous tissue. The best description I ever heard of what storiform means was from a pathologist. I have to give him credit. I don't want to, but I have to give him credit. Helicopter in a wheat field. You know, helicopter's landing and the wheat sort of looks like this. That's the storiform pattern, sort of the pinwheel pattern. Helicopter in a wheat field. You'll never forget it now. Treatment is observation of most of these things because they're not symptomatic. And if they're symptomatic, you can scrape them out and bone graft them. And by golly, even if you leave a little bit behind, if you just get in there and mostly get it out and bone graft it, they're going to heal anyway. Here's an example of a kid I saw a couple of years ago with minor trauma that fractured through this NOF, and we scraped it out and bone grafted it and put some screws in, and he did great. And here's what you see, this whirling appearance, some giant cells, hemosiderin. If it's an old lesion, they'll have hemosiderin, and then fibroblast. This is the common picture you're going to see, sort of the whirling appearance in it, and a little higher power. They can be multiple, so-called Jaffe-Campanacci syndrome, which is associated with other things, you know, retinal problems and cafe au lait, mental retardation, so on and so forth. I've written some of those buzzwords or keywords in your Parsons Picks things. But just be aware that these can be multiple, and when they are multiple, they tend to be larger lesions and need surgical intervention because we're afraid of pathologic fracture. Here's another example of multiple NOFs. You see that they're larger and they're in multiple bones here. Okay, desmoplastic fibroma. This is a relatively rare neoplasm. The thing that makes this interest for the board examiners is that this is the bony counterpart to the desmoid. You know, the extra-abdominal desmoid, fibromatosis. This is the bony part or counterpart to it. Same pathology, but occurring in bones. It's usually the metaphyseal region of the femur, tibia, and humerus, although it can be in the craniofacial bones. We don't worry about that because you're not going to see it there. This is not a periosteal desmoid. The radiologists love to use that term. Oh, it's just a periosteal desmoid. No, this is not a periosteal desmoid. This is a separate lesion that's aggressive. Radiographically, it's lytic, expansile, with well-defined margins typically, and it may invade the cortex and even have a soft tissue mass because they can be fairly aggressive. Here's an example of a proximal tibia one that's good size. You can see it fills the whole proximal tibia. Here's one on the distal tibia. Again, that bubbly appearance, fairly aggressive, and you can see soft tissue density in here and a little bit of mineralization, of cortication around it. Here's one in the distal femur, and you can see on MRI the lesion that's trying to crawl out of bone here and fairly extensive. There's the preoperative and there's the postoperative at 1 year. This one I opened up, scraped out, curettaged, burred, phenolized, and bone graft, and he did fine. In years past, people used to say, well, you got to cut the whole thing out and treat it like a desmoid. We're becoming a little less aggressive in that for these kind of things, for example, desmoplastic fibroma. Histologically, what does it look like? Dense, swirling fibrous tissue and dense collagen. It's essentially what a desmoid looks like in the soft tissue. It's a slowly aggressive lesion, and we're not really sure if it's low-grade malignant or not. We're not even sure if the desmoids in the soft tissue are malignant lesions or not, but they're fairly aggressive. Treatment is with aggressive curettage, as I mentioned. Some people will say excise it widely for expendable bones, and you see the recurrence rate is still reported to be up to 40%. Same problem in bone recurrence as we have in soft tissue recurrence, desmoplastic fibromas. Histologically, dense fibrous tissue with some vascularity in it. Here again, here's the bone, here's the dense fibrous tissue. Now, this arrow here is pointing to this fact that there are these erosive changes, but you see no osteoclast there. This is a good time to remember to tell you that metastatic disease, sarcomas, whatever they are, don't just push the bone out of the way. They're not. No, osteoclasts take the bone away. So anytime there's bony destruction in metastatic disease, in anything, it's because there's been osteoclastic activity. Just ingrain that in your head, because that may be one of the basic science questions that you see is, tumors here, blah, 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 blah. The bone destruction is caused by, and the answer would be osteoclastic activity, because that's what destroys bone. It's not the tumor, it's what the tumor does to activate the osteoclast. Again, just another example of a proximal femoral lesion, very aggressive with some soft tissue extension that was resected. Okay, this is a rare one, fibrosarcoma of bone. And I wouldn't get too hung up on this, but for completeness sake, we're going to mention it. This is essentially fibrosarcoma, much like you see in soft tissue, but in the bone, and is treated the same way as osteosarcoma would be. Chemo, resection, and chemo. These are in older people, however, and again, many of them around the knee, pelvis, or proximal humerus, just the same old Femester's law. Pain, swelling, focal tenderness, and radiographically, these are purely lytic lesions with very destructive and ill-defined features. Histologically, you see the same herringbone pattern. Treatment is the same. Low-grade lesions don't get chemo, but it's very rare for them to be low-grade. In general, it's high-grade, and you have to give them chemo, resection chemo. But here's the rub. I told you yesterday that chemo, the morbidity and mortality with chemo is bad. And if it's an older person, they may not tolerate it, because then you're sort of stuck between a rock and a hard place. You want to get it out, and you want to give them chemo, but there may not be a lot that you can do because they won't tolerate it. Prognosis overall is poor because these things are so aggressive. 30% at 5 years for high-grade lesions, and low-grade lesions do pretty well, 80% at 10 years. But it's pretty unlikely that you're going to see a low-grade lesion on your board exam. Here's another example, fibrosarcoma of bone, destructive soft tissue mass, looks essentially like a lytic osteosarcoma, and treated with a just femoral resection and rotating hinge. And here's what you see. Here's the herringbone spindle cell pattern. All right? As we get to soft tissue sarcomas this afternoon, you're going to see this blur of spindle cells, and you're going to go, oh my gosh. Trust me, there'll be one or two on your test. You just kind of have to sort of recognize patterns. But by and large, you'll be able to do okay because you won't get inundated with a bunch of these things. And you notice that for the spindle cell lesions, they don't necessarily look all that aggressive. You have to recognize the pattern in this to recognize what it is. Fairly cellular, spindle cell. This, it looks more aggressive than the lower power. Okay, so that's the end of that chapter. Everybody's doing okay, right? We still got plenty to go, but we're doing great. Okay, next topic is histiocytic lesions of bone, benign fibrous histiocytoma, and malignant fibrous histiocytoma. So BFH is not a very common lesion and probably not one that you see on your board exam, but one you ought to be aware of, I think, just for review purposes. It's pretty rare. There's no sex or age predilection. Ilium and the ribs are most common, but you'll probably see it in the tibia or in the femur. And radiographically, it's this lytic lesion, geographic, with typically a sclerotic border. It may disrupt the cortex, but these are usually more centrally located than an NOF and appear a little more aggressive. However, in the differential of an NOF, this is something that I'll include as a BFH. Pain, again, is a presenting symptom, unlike NOFs, which are typically asymptomatic. So here's another one, demarcated, Lodwick 1A within the proximal tibia. Here's one with sclerosis around it here in the midshaft of the femur, small lesion that was treated with a window, curettage, and a plate. We did this not too long ago. Histologically, you see foamy macrophages, spindle cells, and again that storiform pattern, that helicopter in the wheat field pattern of spindle cells, but not aggressive in appearance. The treatment is curettage and bone grafting, and it's pretty rare for them to come back if you've done an adequate curettage. Spindle cells, giant cells, some loose stroma and vascularity in it. That's pretty much what you see. Now, MFH of bone is something that you may very well see, and here I've italicized what you probably need to remember. Here's your knee-jerk response. 20 to 30% of these are felt to rise from some underlying chronic condition. That's probably what you would get tested on, all right? These are relatively rare malignant lesions, usually older people, although it can be seen in younger people, most again around the knee and pelvis, and if they have a chronic infection or long-standing implant and they have this aggressive fibrous lesion of bone, that's probably what they're trying to show you. Here's an example of a distal femoral one, soft tissue density inside, the MRI, and resected widely because of the aggressive lesion. Here's a proximal humeral one, hot on bone scan, destructive on CT. You can see them both on plain film. This was resected and reconstructed with a osteoarticular allograft. There's the nerve, here's the artery, big old defect there. That's why we have to use the allograft. Or you could use a custom prosthesis if you wanted. Radiographically, as I said, they're lytic and destructive. Histologically, you get the pleomorphic nuclei, the giant cells, the storiform or cartwheel pattern. It looks just like MFH anywhere, except it's inside bone. How do you treat it? How do we treat all bone sarcomas? Chemo, resection, chemo. I sound like a broken record, sorry, because it's, we only have figured out a few things to do. We're kind of dumb bone doctors. Prognosis is similar to osteosarcoma, about 60% at 5 years. And here's an example. Very aggressive looking cells, certainly pleomorphic, the Star Wars scene, with a little bit of spicula bone there. Another very aggressive appearance to it. Chordoma. This one you may very well see as well. Malignant lesion, remember, of the nodal chordal tissue, which occurs at the end of the spine. 85% of them are at the spheno-occipital or sacral areas. And these are insidious onset, painful, vague in nature, which is why, remember, you got to do a rectal exam or do an MRI on somebody who has this vague back pain that just won't go away. Because you don't want to miss this. That's a problem. And radiographically, it's a little difficult to see. So you may see a shadow like this, or some abnormality on bone scan around here, but the CT, this cross-sectional imaging, shows you a big soft tissue mass down here in the base of the sacrum. Radiographically, if you can see it, they're lytic, but often not well visualized because of the three-dimensional appearance of the pelvis. You got to do a CT and or MRI, MRI probably these days in general, to delineate the lesion, and it shows the destructive lesion with the soft tissue mass. Histologically, these are myxoid with spindle cells, and the buzzword for this one is the fossiliferous cell. Okay? In your handout, I talk about sacral nerve roots you have to spare for function. You got to spare 1, 2, and 3 unilaterally, or 1 and 2 bilaterally for them to have any hope of close to being normal function. That's been a question pretty regularly in the past as well. That's in your Parsons Picks discussed in there. Here it is again. Distally, don't see a lot, kind of washed out, but quite frankly, we don't look very closely down to the inferior sacrum and the coccyx when we look at x-rays. We're always, okay, the hips are okay, the rami are okay, wings okay, which is probably why they're missed. Big soft tissue mass, big soft tissue mass. And this is what you see histologically. This is the ant mini you're going to see. There are these lobules of tissue along these spindle cell stromas, and these are the fossiliferous cells here. Okay, pink cytoplasm with a distinct nucleus. Another example, fossiliferous cells has sort of this myxoid appearance. Oh, by the way, I should have told you guys. Everybody knows what myxoid means, right? Ken Ya taught me the best description of myxoid. Snot-like. Looks snot-like. And I swear, that's exactly right. The pathologist will say, well, this is myxoid. And you say, okay, I can see the snot in there. So that's what myxoid means. It has sort of a snot-like appearance to a sort of gray and sort of mucinous appearance. Treatment for these things is wide resection if possible. And often you have to sacrifice sacral nerve roots, which of course is a problem for function. Radiation is added if we can't get a good margin, which is not uncommon. And unfortunately, local recurrence is common. Metastatic disease, while at one time we thought was almost non-existent, it's not true. They do metastasize, and the prognosis is poor. 5-year survival is about 60%, but almost nobody survives 10 years. Here's a file picture of this person here up in the C-spine, and their head's about to fall off their neck. When they have like this, it's just very, very difficult. These are tragic cases in the cervical spine or in the sacrum. You try to give them proton radiation or neutron radiation, something, and they invariably succumb to disease. It's very difficult. Vascular lesions of bone. Here's Henry Mencken. This is Doug Letson. Anybody know Dr. Letson? He works in Tampa. Doug's a good guy. And this gal, I can't remember her name now. It's been too long. But she was a physical therapist there. He doesn't smile like that anymore very often. Dr. Mencken doesn't. Okay, benign lesions. Hemangioma, lymphangioma, Gorham's disease, and the malignant lesions. Hemangioendothelioma, pericytoma, and angiosarcoma. Hemangioma is a bone. It's a rare vascular lesion presenting at any age. A good half of them are in the cranial-facial bones. We see them in the spine. They're typically asymptomatic, but they can present with pain. The lesions can be multifocal. I'll show you an example of that. But remember, this is one of those things that sort of crawls along the bone. Radiographically lytic lesion, mild cortical expansion, and trabecular striations. And there's the classic jail bar vertebra appearance. And this is what you see radiographically. The ones that I've seen have been shown on the tests. The questions that have been accepted for the test have been either jail bar vertebra, which you'll recognize, or sort of the honeycomb appearance. I'll show you an example of that. So here's the jail bar vertebra here. You can see the striations here. Well, that's because you got this hemangioma growing in here, and it's destroying the cross trabeculae and leaving the primary vertical trabeculae there. And so that's why you get this jail bar vertebra appearance on plain film and sort of polka dot on the CT scan. Here's another one. This is what you see on MR. It has a bright signal on T2. We know this is T2 because there's fluid here, fluid bright in the disc. And this is what you see on CT scan. Here's in the distal femur, maybe hot on bone scan. And here's sort of this honeycomb appearance. I think I've got another example of it as well. But you see the lesion clearly involved here in the femur. Here it is. Classic honeycomb appearance to this thing here in the proximal, in the pelvis above the acetabulum. Warm to hot on bone scan, has that honeycomb appearance. Same reason. It's destroyed some of the bone, but you have other trabeculae that persist, and so it gives you that appearance. And here's another one around the pelvis. Warm on bone scan. Histologically, it looks just like a bunch of blood vessels. These are easy to pick up. Dilated thin-wall blood vessels, and the treatment is really variable. If it's asymptomatic, you do nothing. If it's symptomatic and accessible, you can curettage and graft them. If they're not accessible, deep in the spine, or you don't want to have to get to it, or the person's not a good operative candidate, you can give them a low-dose radiation if they're symptomatic, which most of them are not, and you don't have to worry about it. And low dose is usually somewhere in the 25, often or occasionally up to 40 gray, but usually at the lower end of the spectrum. And here's what you see. There's bone. There's all these blood vessels. You're not going to miss this question because you're going to recognize all these dilated blood vessels in here. Some thin-walled, some thicker-walled. Same thing again. Lots of blood vessels. It's blood, some fibrous tissue. These are easy to make the diagnosis. Now, this is a little more rare. Hemangioendothelioma of bone and angiosarcoma of bone. These are malignant vascular lesions that are typically multifocal, painful, and destructive on radiograph. And this is the appearance that you ought to kind of put in your mind, another Aunt Minnie here to put away. When you see a lesion that looks like it's sort of crawling up the bone in multiple spots, and it may have one here and even a skip and another one here, another skip, another one here, anything that you see crawling up along the bone, you got to consider vascular lesion. That's a hallmark appearance of it. So you heard it here first. If you remember it, you'll be a champ. The lesions really vary from low grade to aggressive, and the histology varies accordingly. The treatment is wide resection if it's an aggressive one, and you can curettage it if it's low grade. And the prognosis is really variable. Again, this one's an aggressive one along the bone. Low grade with excellent survival and high grade with poor survival, that kind of begs the question. And here's some examples of endothelioma and angiosarcoma. These are the vessel elements here, now looking more malignant and aggressive. Here they are. But clearly vessels. These are all dilated vessels with more aggressive-looking cells associated with them. So if you're likely to see an hemangioma, and you just need to recognize the bone and the vascular structure there, it's unlikely, in my opinion, that you can see a malignant, angiosarcoma or pericytoma or endothelioma. I think it's unlikely. But just kind of keep that in the back of your mind. Okay, hematopoietic tumors, lymphoma and myeloma. You will see a lot myeloma, or 2 or 3 potentially, and very possibly a lymphoma. Lymphoma of bone. Primary lymphoma of bone is usually NHL, not the non-Hodgkin's lymphoma, not the National Hockey League, but non-Hodgkin's lymphoma. And we may see it in association with other bone and soft tissue sites, or you may see it as a metastatic focus to bone. And this is the kind of appearance you get. Sort of get this washed out, sort of typical round cell appearance in the bone. 50% of primary lymphomas of bone are NHLs, and they're in patients over 40. Pelvis, femur, humerus, and so on and so forth. And pain is typically the presenting symptom. And again, this is an aggressive round cell appearance. And I guess it's a gestalt that I now have after all these years, and hopefully you're learning. But the round cell is this slowly progressive, sort of eats the bone away, not a shark bite, wham, it's gone, like you see in osteosarcoma or fibrous arc, but sort of kind of percolating along. I like to tell my residents the reason is these round cell lesions, just like pus, because they're small round cells, sort of percolate, shuck and jive through the interstices of the bone and destroy it in little bits and sort of leave this kind of shell of bone behind. So that's the typical round cell appearance. But remember, there's lots of different round cell lesions. We're going to talk about some more of them still, but lymphoma is one of the primary ones, usually seen in the 40 to 60 age. Okay, large lesion typically with mottled appearance, some reactive bone. It may be cortically destructive or thickening, and it may appear blastic. Remember, lymphoma is one of those ones that may appear blastic. It's not truly a bone-forming lesion, but it may have that diffuse blastic appearance to it. Don't ever forget that in your differential of a bone-forming lesion. They're typically very hot on the bone scan, and it's pretty common to have diffuse involvement of the bone. So here's a pelvic one. So this looks ratty, moth-eaten. It's hot on bone scan, and you see the changes back here with some soft tissue extension. Okay, clearly something going on that's aggressive. Here's one in the pelvis. Plain film looks a little mottled on one side to the other, but look at the MRI images. Clearly abnormal one side to the other, and you can see on this T2 images all this involvement all the way along. When something's involving the bone all the way along like that, it's commonly going to be lymphoma, maybe myeloma, or if there's not the soft tissue change and all, it may be Paget's disease, which we'll get to, but it'll have other appearances. But lymphoma is one of the ones you immediately go to when it has diffuse involvement of the bone. Here's another gal that I've treated recently, distal femoral. Not a lot to see on plain film, but look at this. Look at this involvement up and down the canal. So once again, diffuse involvement, but going to be round cell-like because it's not doing a lot to the bone. And here's another one. We actually just published this last month in the skeletal radiology. This is a periosteal lymphoma. See little changes here, something ticking that periosteum off, little soft tissue mass, very hot on bone scan, it turned out to be lymphoma. What do you see histologically? Mixed round cell infiltrate. The most common type in the bone is large cell or mixed small and large cell types. So you see this. And we're going to see lots of round cell lesions here coming up this afternoon, but I'll try to point out how they're different. This is different because it's a mixed cell population. This is not monotonous. This doesn't look like myeloma. It doesn't look like Ewing's. It doesn't look like pus. And really those are the four things you're going to see. So lymphoma is what this is, mixed cell population. How do we treat them? We irradiate them. If the skeleton is structurally okay, we just irradiate them and let the chemotherapists do their thing, because this is sort of a marrow-packing disease. They don't often need surgery, and they'll do okay. Surgery is rarely used for local control, but sometimes you got to do something if they fracture. And sometimes they'll fracture after you biopsy them to make the definitive diagnosis, unfortunately. So here we go. Here's the little island bone. Lots of round cells, but look at this. These are all different in appearance, okay? These are not the clock-faced nuclei that you see in myeloma, and these are not the monotonous cells you see in Ewing's, because there's too much cytoplasm anyway, and they're too ununiform. So lymphoma, this is the picture you're going to see right there. Same thing. They're different. They're slightly different. Myeloma. You absolutely positively are going to see a myeloma on your board exam. Just expect it. Plasma cell malignancy, usually patients over 50. So the round cell continuum I like to give to my residents is very young get Wilms or metastatic neuroblastoma, right? And then in the first 10 years or so, they get EG. And then from 10 to 25, they get Ewing's, right? And from 30 to 50, they get lymphomas. And from 50 out, they get myeloma or Mets. Okay? And the Met can be a round cell from the lung or whatever. But that's kind of the continuum. That's in your Parsons Picks thing as well. But if you kind of remember that, you're in good shape. And, infection could be anywhere in there as well. Because remember, infection is also a round cell lesion, so to speak. But we usually pick that up differently. Okay. Myeloma is the most frequent neoplasm presenting as skeletal lesions. It's in the axial and proximal appendicular skeleton. And these people, here's a clue that they'll often give you in your question. Pain, anemia, perhaps a history of infections, they have some renal failure, proteinuria. These are the kind of presenting symptoms. So in the question, if they give you, they give you this anemia or rundown or so on and so forth, or history of infections or renal problems, you got to be thinking marrow-packing disease, got to be myeloma. And then you go on. The questions are designed to give you information that's salient to the diagnosis. Trust me. Somebody asked me that yesterday, so I guess I should back up a little bit and mention that. I know you guys all hated taking the OITE. So did I. But the OITE, I think, is much more obscure than your board exam. Because in the in-service exam, remember, devious guys like me are trying to ask questions to test the residents. Test them, see what they're learning, see what they're figuring out. And then we just kind of disregard some of those test questions if we think they're unreasonable. But the board exam is designed to see, do you know it? And this is basic stuff, and what's going on. So if statistically you've done okay in the OITE, and that means if you've done better than the 30th percentile or so, your chances of passing the boards in this country are like 99%. Okay? So I'll be feeling pretty good about it. All right? No, and if you were in the lower 30 percentile, come see me afterwards. All right. Myeloma. 50% patients have elevated creatinine, 30% with hypercalcemia because they're mobilizing all this bone. They have amyloidosis about 15% of the time, and radiographically get these punched out lesions. Sometimes they're expansile. It gets sort of osteopenic appearance. Occasionally you get a focal lytic lesion that's present as well. Remember, a third of these are cold on bone scan, so you don't get the bone scan, you get the skeletal survey. We mentioned that yesterday. And histologically, you have the classic appearance of the sheets of plasma cells. So here's the typical round cell appearance here. Something's not right. It's kind of washed out. Something's percolating through this bone. Same thing here. And in the spine, in an older person that's got back pain in the spine and they're osteopenic to begin with, on plain film, you just have to get an SPEP and UPEP or work them up for myeloma somehow, because that's just going to be in the differential. They got persistent back pain. It's just worth doing it once to make sure they don't have something going on. Here's some other examples. Here's a spine lesion here. Here's a proximal radial lesion here. Here's a proximal femoral lesion. Sometimes they can be focal like this and destructive. Now, could I look at that and say that's myeloma? No. I mean, you have to biopsy it. But something like this, you say, well, that's a round cell, sort of infiltrative. Here's one that clearly has that classic appearance of kind of moth-eaten all the way through there. Round cell, diaphyseal. In a young person, you'd think, could be Ewing sarcoma. In this age group, probably a myeloma. Here's an example of one, the distal femur right here. But look at the bones. Oh my gosh, all the way up and on both sides. You see on this T2 coronal. On the T1, you can see the involvement here. And look at that, fills the bone. This is one that needs to be fixed. I'm going to take just a second to give you a pearl of wisdom that will be invaluable to you in your practice. See this T1 image here? Everybody see that? When you image T1, the fat is bright. We talked about that yesterday. If you have something in the marrow that is as dark or darker than skeletal muscle, that is a pathologic finding. Okay? So this is a trick. This is a secret the radiologists don't share with us, but I'm sharing it with you because you're going to look like a champ, and it'll help you. If you see something on the T1 image in the marrow that's as dark or darker in signal than the skeletal muscle, that's a pathologic process. If it's not as dark or lighter, then it's probably just marrow abnormalities, red marrow maybe, whatever, and it's not of significance. So that's the key that you use to looking at image or lesions within the marrow. You heard it here first. Well, maybe you didn't. Maybe you already knew that. Proximal humeral lesion here, destructive pathologic fracture, pretty good size thing. And you see it very bright on T2, and on GAD it's hyperemic with some soft tissue extension. And there's not a lot to do, and you can't put that back together very well, so we gave him a proximal humeral replacement. Remember, you get an M spike on your serum electropherogram. It's easy for me to say. And those are usually IgGs. The M spike means myeloma. It doesn't mean IgM. It means it's a myeloma spike. They're usually IgGs, occasionally IgAs. What's abnormal? More than 10% of plasma cells in the marrow aspirate. Normal is 2 to 3%. So absolutely more than 10% is diagnostic. If it's 7 to 10, it's kind of the gray area, but still people sort of treat them. The urine may show bench-Jones protein, so you probably have to check that UPEP. And the treatment is chemo and radiation, unless they need stabilization of the bones because the bones are falling apart. So this is a marrow packing problem, much like lymphoma, and chemo and radiation is what you give them unless their bones are falling apart. Prognosis is poor in general, averages about 24-month survival, but I have a lot of patients who are years and years with it suffering along, so they don't all just immediately die. And here's the Ant Mini. Here's the round cells, but abundant pink cytoplasm, eccentric nucleus, okay, with this clear zone around. It's called a Hoffa zone. Oh, see, the pathologists are going to go crazy when you tell them this stuff. There's Hoffa's clear zone around them. Here's the eccentric nucleus and the chromatin that's sort of, well, you got to use your imagination, but sort of clock face. That's a messed up clock, but it's a clock. But anyway, you get the idea. Solitary plasmacytomas, sometimes the pathologists, the hemonc guys will say, it means there's no diffuse marrow involvement on the aspirate, on the marrow aspirate. Most of us believe they'll probably go on to develop multiple myelomas, and you treat the solitary plasmacytoma with radiation just like you do in myeloma. But they don't get chemo because the hemonc guys say, well, I don't have systemic disease. What do you want me to do? And then you say, okay, fine. Well, I'll just bring the patient back next year when they have a positive marrow aspirate. So then you just have to sit on them. Remember, there's a rare osteosclerotic form. Now, I know that your guys took an OITE about 2 or 3 years ago that showed you this because I remember the question. Osteosclerotic form associated with polyneuropathies. The lesions are lytic or sclerotic, and the so-called POEMS syndrome. And that POEMS syndrome is polyneuropathy, organomegaly, endocrinopathy, M protein skin changes. This is the osteosclerotic form of myeloma. So while most of the time they're lytic, occasionally they can rarely be sclerotic like this, and they may throw in one of these things. And typically what they're asking is, do you recognize that they have endocrinopathies or a neuropathy associated with POEMS? So just tuck that away. You heard it here and you'll know it. Again, treatment with radiation, but remember the neurologic symptoms may not go away. Okay, unknown origin tumors. Giant cell Ewing's and PNET, which stands for primitive neuroectodermal tumor, and adamantomas. We'll spend a little bit of time on that. Giant cell. You're going to see a giant cell. They're common enough. Everybody recognizes them. Unfortunately, everybody calls everything a giant cell, but you'll know the difference. These are aggressive benign lesions in 20 to 40-year-olds. Remember, ABCs are in younger people. Chondroblastomas are in younger people. When young people get giant cells, they show up in the metaphyseal side of the physis, not on the epiphyseal side. If it's epiphyseal in a lung person, it's probably going to be a chondroblastoma. So giant cell will be on the metaphyseal side. 60% of these lesions around the knee, same old Fenrischer's law, distal radius. Sacrum is also another place, and you get neural deficits. Remember that sacral one. I'll show you an example of one later. Rarely they can be multicentric, so you have to rule out hyperparathyroidism because histologically they look fairly similar to hyperparathyroidism. And then it's often that they have pain referable to the joint involved. So here's the distal radius one. This one is geographic, got a little bit of sclerosis, which is usually atypical, but here's the hallmark, the subchondral in location. Here's a proximal fibular one, okay, is lytic, and you can see that the bone is reacting a little bit around it in the periphery. Very hot on bone scan. On the images you see here and postoperatively, what's missing here? The fibula, because we took it out. Radiographically lytic, eccentric, poorly defined, but subchondral in location. Pathologic fractures are not that common, about 10% of the time-ish or so. And histologically, you see giant cells with proliferating mononuclear cells that, if you put them all together, look like the giant cell. That's sort of the hallmark of the disease. The giant cells have the same appearing nuclei as the background cells, and occasionally you can see some reactive bone or mitotic figures. Don't be concerned if you see that. Here's another example. Eccentric, subchondral, little expansile in the bone. On the lateral image, what's this finding right here? You guys have already forgotten from yesterday. Donut, yeah, all right, the donut. Remember, that means it's cystic-like. There's no tumor right in there, or no bone, rather, to react. And here's a T1 image, classic finding. Nice demarcation between the fatty marrow and the tumor. Gadolinium has mixed hyperemia. T2 is edematous. And here is postoperatively treated. This is about 6 months post-op. And notice what I've done here, which is what we're trying to do, many of us now, is to take bone graft, autogenous bone graft, and put it right up underneath the subchondral bone here and then support with cement underneath so that we actually have some of their own bone to support the cartilage rather than their cartilage resting on this hard old cement, which you know is going to wear out. Is this going to make a difference? Well, you know, the Italians at the Bologna Institute said, yeah, we think it does, and I kind of agree with it. It makes sense to me. Here's a proximal humeral lesion. This one was treated with curettage and some rebar. This is 4 years post-op. Distal radial lesion. This is a big one here. This one we had to resect. This one here is reasonable just to curettage. It's all the same kind of appearance, subchondral. Here's a gal I saw a number of years ago with this distal tibial lesion, not a real common location for it, hot on bone scan, expansile, and you can see, again, the sharp demarcation, giant cell on the T2 image, and here's an osteoarticular allograft put in there, and she's done relatively well. That's not a normal ankle for her, but once again, it beats not having an ankle bone. Histologically, what do you see? A bunch of giant cells. This one's easy. And these nuclei behind, if you coalesced them all together and roped them together, would look just like the nuclei in the giant cell. The treatment is aggressive exteriorization and extended intralesional curettage, burring and washing. We've kind of talked about the same thing for all the locally benign but aggressive lesions. Phenol cryotherapy. The defect is reconstructed with bone, cement, many of us use, or a combination, which I was just talked about in the subchondral area. Recurrence rate, again, that 10 to 30%. With cementation or with current techniques of carefully treating them, about 3%. So here's the first inclination that we have that some of these benign aggressive lesions are probably only have a recurrence rate of 3, 5, 8% in the more common literature, more current literature. Why is it different with cementation? Because in the past, people would open it up, make a little hole, kind of scrape it out, and say, okay, I think it's all out. and shove some graft in there and close it up. Well, guess what? There's still tumor in there. That's why you have to be aggressive. But when people cement things, hey, we're orthopedists. We know how to use cement. You got to clean, you got to wash, you got to be real meticulous, be careful, and shove that cement in there, and it probably made a difference because they opened it up completely. That's the difference. Here's an example in a kitty just to remind you, when they show up in a skeletally immature person, look at that. It's on the metaphyseal side of the bone. Another just a radius example, hot on bone scan. Real destructive, the soft tissue mass, the quadratus here is around it, and fusion. Use the fibula, proximal fibula to graft that one. Another just a femoral example. This is a common appearance to it, common appearance on T1. And this is what I mean by exteriorize. There can be no nook and cranny not open. If you're not sure if you see it all, then take some more cortical bone. There should be absolutely nothing that you cannot visualize. Not hope you feel, not hope you see, but actually see. And then once you've done that, you've got to burr back a little farther because those little cells will crawl into the interstices of the bone, so you have to extend it. Again, extended intralesional curettage. If I'm on my horse, tell me to get off, but I want you to understand. That's how you prevent it from coming back. And then we pack it with cement or whatever modality you choose to use. This one may metastasize to the lung, looks like chondroblastoma. I told you yesterday. Usually a distal radius lesion is the one that was going to metastasize. And it's mostly those that have local recurrence that are distal radius lesions. So it's the upper extremity ones. There is no correlation to the histology and the clinical aggressiveness. And so there's a wide range of these tumors from clinically quiescent to a frankly malignant giant cell lesion. Okay? And you can't tell by looking at it, it's a clinical behavior. That's one of the nuances of this tumor. Radiation sometimes has been used for inoperable lesions, but beware malignant transformation. We worry about it up to 15% of the time. Some people have talked about embolizing these things. I have no experience with that. Some centers say that works. I'm a little skeptical personally because I'm not sure that you're really controlling the disease process, but there are reports that that may do the trick. So here's an example of a patient I saw just a few months ago who had had this treated by someone that was not a tumor surgeon. So if you're going to do it, guys, that's fine, but do it right, okay? Who probably had an inadequate exposure. So he has bone here, he's got pain, and look at this, he's got some lysis around here, which is what you're absolutely going to see in a recurrent lesion. On the MR, there's absolutely no question that here's the cement, and here's recurrent tumor and cement. And the recurrent tumor is all the way up here to the subchondral area. So here's 6 months out after I went back and redid it, and here's his own autogenous bone up underneath the subchondral surface, and here's his cement packed in there. And I think he's going to do okay. Here's a lesion of the pelvis, and this is no small lesion. This is all tumor out here and all tumor out here. Like I said yesterday, sucks to be this person. And metastatic because it was aggressive. Still, the same appearance, classic giant cell. So remember, when you see an epiphyseal lesion of bone, think about giant cell tumor or chondroblastoma. And the other thing we've thrown into that differential diagnosis is clear cell chondrosarc. I'm not showing you an example in this review because it's not a very common thing, but in a proximal femur or proximal humerus, clear cell chondrosarc is another lesion, would be right there in the subchondral area. Fairly uncommon, but that's the one to think in your differential. Okay, another one down. That's good. We're doing okay? You want to stand up for a second? Everybody all right? Stand up for a second, stretch in place while I pull this next one up. The giant cell, if it occurs with an immature patient, is going to occur on the metaphyseal side of the bone, not the epiphyseal side. Okay, so we have less than 2 hours to go, and we're going to easily make it with the stuff we have left. So. No, that's a Lodwick 1A, radiographic appearance. Lodwick 1A, geographic sclerosis. Okay, so the question was, did I refer to an NOF as a 1A lesion? And the answer is Lodwick, not Enneking staging, but rather a Lodwick radiographic appearance 1A, geographic with sclerosis around it. Okay, I'm not trying to confuse you on this one. Okay, everybody's favorite, Ewing sarcoma. Round cell sarcoma in young patients, 5 to 25 is what the literature says, but most of the time, if they're under the age of 10, they're probably, the round cell lesion they're going to have is probably a histiocytic one rather than Ewing's. Under the age of 5, consider leukemia or metastatic neuroblastoma, as I mentioned, and over the age of 30, think about lymphoma or metastatic carcinoma. This is the third most common primary sarcoma bone after osteosarc and chondrosarc, which we've already discussed. Here's a classic example of a long-standing case, diaphyseal with destruction and periosteal reaction around in the soft tissue. Most of these are present in the pelvis or femur, occasionally the tibia and the humerus. If it occurs in the ribs, just for your information, it's called an Askins tumor. Why, I don't know, but it's still the same tumor. Radiographically, it's ill-defined, permeated or moth-eaten. Again, that same round cell appearance of the diaphysis or the metaphysis, lytic or variable reactive bone formation, the onion skinning or sunburst we talked about yesterday, because the periosteum is irritated. These things are shucking and jiving out the bone. They anger the periosteum, and you get that sunburst appearance or that onion skinning appearance. Okay? So here's an example of a lesion of the pelvis, inferior ramus, which is not well seen, but on MR, it's a huge soft tissue mass associated with it. And here's one of a tibia with clearly some onion skinning here and a little of the hair on end or sunburst appearing on this other side. Here's another classic example, a kid I treated many years ago, diaphyseal lesions and onion skinning here, big soft tissue mass associated with it, hot on bone scan, again, big soft tissue mass, and you see it's inside the bone and outside the bone, clearly malignant. These things are widely resected. This one I reconstructed with a intercalary allograft, and he promptly pussed out and ended up losing his leg. So, unfortunately. Better outcome on this one. Diaphyseal lesion, looks kind of funny, big soft tissue mass. In the shadow you can see here, on the T2 images you can see big soft tissue mass inside the bone and out. On the axial images here, big soft tissue mass around in his arm. And this one underwent chemotherapy, a resection, and he underwent vascularized graft in conjunction with an allograft strut, and he's 10 or 11 years out and doing fantastic. Proximal femur, here we go, bright on bone scan, sort of this lobular appearance. Now, if I were to look at this, I couldn't tell you whether this is a chondroid lesion or not on this MR appearance because it's sort of lobular and bright. But the bone appearance is more that of a round cell lesion because it's sort of washed out in that area and no mineralization. Very hot on bone scan, much more than a chondroid lesion would be. And this was a proximal tibial Ewing's that was treated with a rotating hinge. She's about 7 years out and doing okay, except I heard she got put in jail. So that wasn't my fault. Give me a break. Tibial lesion here, onion skinning, changes here, hot on bone scan, extension up and down the canal with a little bit of soft tissue change. That's the classic appearance to the Ewing sarcoma or the PNAT. Remember, 90% of these have the 1122 translocation. And here's another one. Pain, fever, leukocytosis, anemia, and elevated sed rate is a common presentation. Why? Because these are sort of a marrow packing, if you will, process within that bone, and they cause sort of inflammatory response. Histologically, you see sheets of monotonous, small, smudgy blue cells with scant cytoplasm. So monotonous, smudgy sheets of cells, those are all the buzzwords associated with this. Here's a patient years ago with a pelvic Ewing's with big soft tissue mass who absolutely refused surgery and had radiation and survived with the radiation. Well, at least she's so far. Here's a gal who has this femoral lesion, changes, lytic in the bone, which is a little unusual for Ewing's, and very hot on bone scan, soft tissue mass associated with it, and lung mets, big old lung mets. And she succumbed to the disease pretty quickly. Now, you see pseudo-rosettes with Ewing sarcoma. These are cells that line up like this with necrosis in the center. And in neuroblastoma, you see true rosettes. You see the cells lined up like this with little microtubules in it. And I've got an example of that later. So this is one feature that you may very well be shown and have to recognize as associated with Ewing sarcoma. True rosettes in neuroblastoma, pseudo-rosettes in Ewing's. Lung mets are pretty common, so make sure you work up their chest. And pelvic lesions have a pretty poor diagnosis. The distal extremity lesions are better prognosis, kind of like chondrosarcomas. Is that because we get to them easily, they're more easily resected? Don't know. Probably so. Probably the pelvic and axial lesions are more difficult to get at, and they've been growing for longer. And this is the problem. Here's the smudgy, round cells, and they sort of push their way through this skeletal muscle and go everywhere, which is why the big soft tissue mass is difficult to treat, except it's very chemosensitive. And here they are. Here's the round cells. They're pretty uniform in their appearance. They have very scant cytoplasm, and they're smudgy. They're not quite clear. They're not very distinct. And here's the pseudo-rosettes associated with them. So this is the kind of picture you're going to be shown. The treatment is chemo, resection, and chemo. Some people will say chemo and radiation because they are very radiation sensitive, but the push has clearly been, at least in our opinion as from Musculoskeletal Tumor Society, for surgery over radiation, but the data is not clear. The radiation oncologists say, well, we can do just fine by radiating. The problem has probably been that in the past, the bias has always been, well, we don't know what to do with these people. You radiate them. And so they irradiate them and got data. And then the ones that we operated on did better because the surgeon says, well, I can get that out. I can't get that one out. You radiate that one and operate on this one. And so it skewed the data. There are no good studies, multicentric studies across the board to really show us. Some of the data suggests that people that are radiated alone have a focal recurrence, that abnormal tissue that persists there. So for your board purposes, chemo, resection, and chemo is probably what you're going to pick. It's because it's not radiation oncologists writing the questions, guys. It's surgeons. Prognosis of overall survival is about 60 to 70%, a little bit better than osteosarcoma, roughly the same, maybe a little bit better. Only 40% of pelvic lesions survive, however. And people that present with MET, it's a poor prognosis, about 15% of them that survive. Adamantinoma. This is a rare lesion of the tibia, occasionally the fibula, patients over 20. It can be another size, but pretty rare. Occasionally, or I should say 50% of the time, you get synchronously involved, the tibia and fibula, both bones. And this is one that gives you pain, deformity of the tibia, and with an anterior soft tissue mass. Radiographically, almost all involve the mid-tibia, the well-demarcated mixed lytic sclerotic lesion. Histologically, you get these epithelioid cells in a fibrous stroma, and we think this may be a continuation or continuum of fibrous dysplasia, or excuse me, osteofibrous dysplasia, so-called Campanacci's disease. So these are the classic pictures you see: anterior bowing, lytic destructive lesion of the anterior tibia, and big soft tissue mass associated with them. Frequently we'll have a soft tissue mass, unlike osteofibrous dysplasia. And what you see is fibrous tissue with these nests of epithelioid cells within it. So epithelioid appearing cells and the fibrous tissues, and that's adamantinoma. This has been less popular over the last maybe 5 years than previously, but was commonly a question in the past. And this is the appearance, again, fibrous tissue and these epithelioid cells that are darker and stained more darkly. Treatment: wide excision, local recurrence if you have inadequate margins, which kind of begs the question. It's a low-grade malignancy. Nonetheless, sometimes lung mets will develop, and the prognosis is variable, but typically good because it's relatively low-grade and we can get them out. We don't have to give them chemotherapy, usually just cut them out. Okay, tumor-like conditions of bone. ABC, histiocytosis, osteofibrous dysplasia. These are some good ones in here, ones you're definitely going to see. ABC, you probably will see an ABC. Cystic, appearing under 20 years old. These are young patients, maybe primary or arise in a pre-existing lesion of some kind. I've got some of them listed there. About a quarter of them in the vertebra, about 20% in the major long bones, and sometimes in the hand and feet. But virtually it can appear in any bones. And here's this expansile appearance. This is a so-called Inneking's finger in the balloon sign. Here's the expanded bone around there, but the bone, you can see the outline of the cortex involved, almost if you, as a kid, had taken the finger and shoved it inside a balloon. You see the lesion around it and the cortex on the inside. So here's a proximal femoral lesion. It's lytic, and it's bright on T2, has rim enhancement on gadolinium, which means there's no gad uptake in the middle. Well, duh, because it's sort of cystic-like, and it's dark on T1. So this is a great picture right here. It shows you all the things. Most cystic lesions do that, have what's called rim enhancement. Pain and swelling is common. It's eccentric lytic expansile lesion, like we talked about. And fluid-fluid spaces are commonly seen. So here's a fluid-fluid line. There's no such thing as straight lines in nature. This is a fluid-fluid. But remember, you can also see fluid-fluid other things like giant cell tumors, which can be cystic. You can see them in chondroblastomas. You can see them in simple bone cysts that have a bleed. And you can see them in fibrous dysplasia even. They have cystic degeneration. So just because the fluid doesn't mean that's exactly an ABC. But probably, for your board question, it's going to be what they're trying to show you. Hot on bone scan. Here's a scapular lesion, lytic, expansile, soft tissue density within it on the CT scan. And here's the giant cells and the spindle cells alongside of it. This one's more of a solid, doesn't have the legs of blood. Here's a classic appearance, the diaphysis, sort of little wisps of bone around here you see on plain film. On the CT scan, you clearly see an outline of bone here. Same thing, soft tissue density within it. Here's an MRI, nice fluid levels on the MRI, on the T2, and on the gadolinium, you see some rim enhancement and some hyperemia in the tissues around it. So once again, classic appearance of ABC. Here's that one I showed you in the yesterday, expansile of the calcaneus. This guy had been walking along. This is a guy who's from the Army, got referred to me. And he said, for 3 years now, my boot size has been getting bigger, and I can't figure out. And I said, well, this guy was not the sharpest tool in the shed, unfortunately. And as my father would say, some village somewhere is missing an idiot. But he said, I can't figure out why my boot size keeps getting bigger. And I said, well, you having pain? Well, just recently having pain, which for him was just a few weeks. They put him on Motrin and so on and so forth. And you got this MRI, and you just say, come on. Anyway, nice donut sign here on the bone scan and multiple fluid levels. So this is a classic appearance for expansile ABC. Another one up in the pelvis that I treated a few years ago. Here's 2 years post-op after bone grafting. You know, when you graft these things, the bone doesn't shrink down and remodel. You know, it's still expanded there. It's just the lesion is not active anymore. Proximal femur of a young person, again, fluid, sort of the donut sign, not real hot on bone scan because it's not all reactive here. And here's 1 year post-op after curettage and bone grafting. Histologically relates to blood without endothelial lining, giant cells, inflammatory cells. Remember, if you see an ABC, you got to also think of telangiectatic osteosarcoma altogether. Very good. Okay? Treatment is all just like the other aggressive lesions. Aggressive curettage, extended intralesional bone grafting. Recurrence rate is about that same number, around 25%. In my experience, I think it's lower than that. But if it doesn't occur right away, it's pretty rare after a couple of years. Some adjuvant treatment is helpful. I'd like to phenylize them if they're pretty aggressive. And sometimes we talk about radiating these inaccessible lesions. Again, we're about the sarcomatous transformation. But your board answer is curettage and grafting. And here's what you see. Giant cells, spindle cells, maybe be some bone in there. Giant cells, spindle cells, and blood. That's what they're going to show you. Simple cyst, another common one on your board exam. Cystic lesion, metaphysis of bones, typically in patients that are young and in the long bones. 80% of them are in the proximal humeral and the proximal femurs of young people. Older people get them in the ilium, the talus, and the calcaneus, and sometimes we refer them as calcaneal cysts or talar cysts because they're a little bit histologically different. It may present serendipitously. Johnny sprained his knee, you got an x-ray, well, it wouldn't be his knee. Johnny threw the ball and has shoulder pain, they get an x-ray and you see it. Or they may have pathologic fracture. Sometimes they can be fairly expansile like this. Proximal humeral lesion here, you can see the density is pretty low because it's fluid. Bright on T2, dark on T1. We think there's a physeal disturbance that causes these things and maybe is resorptive erosion from increased hydrostatic pressure that causes things to form. We don't know. We don't know what they are. Radiographically, there's central lucency with thinning of the cortex, modest expansion, and I have a case that proves this wrong, but this is a Springfieldism. Width of the bone typically is no more than the width of the physis, and I would have said that was absolutely always the case until a case I saw a few years ago that proved me wrong. I told the family it's going to be an ABC, and it was not. It was a simple cyst. I was wrong. It may appear trabeculated, but again, it has the same cystic appearance. Here's one that should expanse on the bone and endosteal erosions. Here's one with a pathologic fracture, and here's another one proximally with this multiloculated sort of cystic appearance. The active cyst abuts the physis, remember, and the latent cyst has a normal bone lining between it. The active cysts are very difficult to treat because they're still in the process of evolving. The latent cysts are much more amenable to treatment. Histologically, there's not much to see. Thin fibrous lining, giant cells, hemosiderin, scattered inflammatory cells, and the treatment is observation or aspiration and injection of steroids, methylprednisolone. Scagliotti did that wrote that article in 1979 in Core and followed up 2 years later with other things they tried injecting. And guess what went away? Simple cysts went away, and anybody want to guess? EG, eosinophilic granuloma, went away when they injected steroids in them. Funny thing is, those both go away if you don't inject anything in them over time. So, I mean, it's a great breakthrough. Another thing from Bologna, and probably it's because they are all going to involute anyway. Let's see. So here's an inactive cyst, and here's an active cyst. And here's the so-called fallen fragment sign. Fracture with a little bit of cortical bone that falls in there, sort of floats around as you put them in position. You know, put them supine or whatever, it'll sort of move. That's supposed to be pathognomonic of a simple bone cyst, and I've never seen anything else other than a cyst. Another wives' tale is that these go away with fracture. They don't. They don't go away with fracture. The bone will heal, but the simple cyst remains. Here's an example of one here. This is a great series right here. A little warmth on bone scan, probably because there's stress in this bone. Pretty good size proximal femur, dark on T1, as dark or darker than the muscle, very bright on T2. And this one was big enough we worried about it, and here's a two-year post-op. Curettage, bone grafting. We put this hardware in because I didn't want the femur to fall apart, and I didn't want to put him in a spiky cast at this kid's age. Here's the case I was talking about. I told the family, oh, we got a little bit of discomfort down there. This was found serendipitously, but the child, of course, as soon as you tell a 3 or 4-year-old there's something wrong with your bone, they start limping. Does it hurt you? Uh-huh. Does it hurt you all the time? Uh-huh. Does it hurt you at night? Uh-huh. Does it ever not hurt you? Uh-huh. It's, you know, you're clueless. So I said, okay, I think it's going to be an ABC. Opened it up. It was a simple cyst. I was wrong. And then you see a 2-year post-op film. Look how nicely that thing remodeled. Almost as if I wasn't there. Although it's a little bit more dense there, but that's the bone graft's fault, not mine. Right. And what you see, bone and a little fibrous lining. Fibrous lining, a little bit of bone. There's really very little to see in simple cysts. Rarely do they show you histology. If you're going to histology, it'll be a close-up like this. Simple, fibrous tissue. Here's a little osteoclast there eroding this thing away, and nothing else, because it's just fluid. Occasionally, they'll invade and cross the physis. As I say, recently, we've talked about injecting marrow or bone substitute into these things. Typically, the prognosis is good. They resolve by adulthood. But you have to follow them carefully for these active cysts because they may recur. And if you're going to inject them with methylprednisolone, the series or the literature suggests you have to do it 2 or 3 times. It won't just go away with the one-time magic treatment. Okay, we're doing great. These are going faster and faster now, either because I'm talking faster or because they're easier things to deal with. Histiocytosis. Here's another one that you're likely to see. Remember, this is a continuum, histiocytosis. EG or HSC, Hahn-Schuler-Christian disease or letter-seaweed disease. EG is the most common manifestation. That's probably what you're going to see on your boards in a histiocytosis question. And it's typically single, occasionally multiple bone involvement. HSC is bone and visceral involvement. And the classic triad they talk about is diabetes insipidus, exophthalmos, and the lytic bone lesion. But that's less than 25% of the patients, so it's really not all that helpful, although it made somebody look good, and they got a paper out of it probably. And letter-seaweed disease, which is uniformly fatal in young people. That means the histiocytic infiltration is everywhere. Brain, liver, gut, bone, and they just don't do well. And here's a typical flat bone appearance. You get sort of this punched out lesion in the bone. Typically the first 3 decades, although I've got a patient of mine who has multiple EGs, who's 60 or 70. It's been treated with radiation, pathologic fracture, won't heal, it's a disaster. But most of these people are younger. Skull, vertebra, ribs, pelvis, femur. Pain and swelling is common presentation, and it shows radiographically, as I mentioned, a punched out lesion. The cortex may be destroyed. Excuse me, there may be periosteal reaction. Sometimes a soft tissue mass, but very rarely, and very rarely expansion. So here's the common appearance in that punched out thing of the skull. Here's a diaphyseal lesion. I showed you this before, bright on MRI. Here's a proximal humerus lesion. Now, if I looked at this, I'd bet money that was a chondroblastoma. Right. I was wrong. Tumors can do whatever they want, but still, I would have picked chondroblastoma in the test. This is just to show you they can be anywhere. Here's a vertebral body and a skull. Here's a big one in the skull. You can see in the CT scan. the destruction there. Here's proximal radius, hot on bone scan, distal clavicle, and here's multiple involvement in the femur. All right? And here's the classic vertebra plana, right there. They're going to show you a vertebra plana. It's the knee-jerk response is EG. And do these things reconstitute? Yes, they do with time, but they never look normal again. And spine lesions will be given low-dose radiation. Here's another one in the flat bone of the scapula, hot on bone scan. Sometimes it's very difficult to see because they're round cell lesions. Remember, this is one of those lesions that can look like anything. Hot on bone scan. Can't really see it very well here, but look on the imaging studies, and thank goodness for MRI, you can clearly see it filling up the body. Histologically, you get Langerhans. Langerhans. The Langerhans cell are the big reactive cells that you see with inflammatory lesions, with spores or fungi or whatever. Langerhans cells are for EG, and they get the characteristic groove in the nucleus. Eosinophils may or may not be present, despite the fact that it's named, although typically in your board exam they'll show you eosinophilic lesion, and they may have mitotic figures. The treatment is variable. This is a self-limiting disease. Some people think it's not truly a neoplasm, but rather an inflammatory process. But typically observe them. If you've established a diagnosis, you can observe them, or you can give them low-dose radiation, 600 centigrade, that's pretty low dose, or you can curatize and bone graft it in a lesion that you're afraid that's going to break, or you're already there anyway. Mencken used to claim that by virtue of letting the air of the outside world in with your curette, they'd go away. Well, that's clearly not science behind that, but most of them involute. And so the point is, you don't have to be real aggressive in treating them. Histologically, here's what you see. A lower power, you see lots of eosinophils. Here are the Langerhans histocytes, some eosinophils over here. And here they are. And okay, now trust me on this one, guys. Here's the nuclei, or rather the Langerhans cell, and here's the sort of the cleft, okay? Cleft here, cleft here. You guys are going, you're on drugs, Parsons, what are you talking about? Trust me, there's a cleft there, cleft here. Anyway, Langerhans, okay? And the one thing that used to show up all the time in the test, and it's sort of fallen out of favor, but you never can tell, is the racket-shaped Bierbreck bodies, that are these organelles that are inside them. You only see them if you get a EM, electron microscopy. But that's, only remember that because that's side association. Someone's showing a Bierbreck body, you go, yeah, EG, and you move on. So that's where I put that in there. Okay, fibrous dysplasia. You will see fibrous dysplasia, absolutely. This is a developmental abnormality of bone. It can be monostotic or polyostotic, usually in the first 3 decades. Swelling or deformity is present with the polyostotics because they can be pretty disfiguring, or it can be asymptomatic in the monostotics. Ribs, craniofacial bones, femur, tibia, so on and so forth with monostotics. And this is a common appearance to it. You get slightly expansile bone, sort of this ground glass appearance to it, and sort of a wedge-shaped ends of the bone. Here's one that's polyostotic. Both the tibia and the fibula is involved. Here's a mid-diaphyseal lesion that's slowly endosteal erosive. This is a humerus right here. Here's a tibial lesion, lytic right here, slightly expansile, endosteal erosion, and a mid-radial lesion. In the proximal femur, they have a tendency to sort of wide variety of appearances. Remember, this is one of those things that can look like anything. Here, this is geographic and well demarcated, but lytic. This person was symptomatic, and so gets this kind of treatment here. You can see it bright on T2 images. Here's a proximal femoral lesion that's of good size, okay? Fills up the diaphysis and the metaphysis. Signal on T1, T2 bright because it's wet, and on gadolinium, variable blood flows, variable hyperemia in this thing. This has cystic degeneration that's taken place in it. Fibrous dysplasia does undergo cystic degeneration, and commonly in the proximal femur it does that. The polyostotic form is usually lower extremity and homolateral. Even severe forms usually affect only one side of the body, and it's very uncommon for vertebral involvement. So if someone's showing you a funny-looking vertebra, it's probably a vertebral body, it's probably not fibrous dysplasia. They're probably trying to show you Paget's disease. Endocrine abnormalities are common, and the common one you hear about is a McEwen-Albright syndrome, which is precocious puberty, cafe au lait spots, and the multiple bony lesions. Other endocrinopathies, acromegaly, hyperthyroidism, Cushing's, and so on and so forth. Here's some changes in the skull, polyostotic. And here's some file films of bad deformity, disfiguring, and this is the so-called shepherd's crook because it's abnormal bone. Radiographically, we already talked about ground glass, lytic, often well defined, occasionally a sclerotic rim. We'll usually have cortical fitting like you see here and modest expansion of the bone. And histologically, what do you see? The Chinese characters, C's and O's, dense fibroblasts that are immature, occasionally some cartilage, but you will not see osteoblastic rimming. No. If you see osteoblastic rimming, osteoblasts on the trabeculator showing you, never pick fibrous dysplasia because it does not have it. So here's a proximal or an acetabular lesion, same thing, fibrous dysplasia. And this one we biopsy because the person's symptomatic and then grafted it afterwards with synthetic stuff. Here's another proximal femoral one and has that sort of unusual appearance here, sclerotic at the periphery and mixed in the center and very symptomatic and got this treatment here. Here's a tibial lesion, common appearance to it, slightly expansile, wedge-shaped at the ends. Most cystic lesions, Dan Rosenthal used to say at MGH, cystic lesions are rounded in appearance. Fibrous lesions are more angular in appearance. That's another clue that will help you when you're looking at radiographs. And put a rod in this thing. And notice we put cortical bone around here. Fibrous dysplasia heals with fibrous dysplasia. If you scrape it out and put bone graft in there, guess what you're going to have in another year or two? Fibrous dysplasia. Okay? So if you have to treat it with metal and you're going to graft it as well, you got to use cortical bone, and typically we use cortical allograft because it's not resorbed. A lot of it stays there, and you have some integrity then as the thing recurs. So once again, to refresh your memory, the big five: fibrous dysplasia, infection, metastatic disease, chondroid lesions, and EG can look like anything. Here's polyostotic fibrous dysplasia, another example of the proximal femur. And here's a case I just saw recently. Fibrous dysplasia with cystic changes in it, but look, it's not hot on bone scan. If this was an ABC, you'd expect it to be hot on bone scan. Fibrous dysplasia is not particularly hot, but fairly diffuse involvement. Once again, can look like anything. Here's the classic look. How much ground glass there is depends upon how much bone is being formed there. Here's the abnormal woven bone, but it's not interconnecting appropriately. Here's the C's and O's with all this fibrous tissue. There's no marrow elements whatsoever in there. And see, you have this woven bone with no rimming osteoblasts. Fibrous tissue, some vascularity, no marrow elements, no rimming osteoblasts. I say again, no rimming osteoblasts. Enneking refers to this as an island of trabecular of immature bone surrounded by schools of fibroblasts, is how he describes that. Treatment is observation in most patients, in fixation and grafting for symptomatic lesions of high stress. Sometimes, if there's a lot of it in the neck, we'll try to put struts in there. I've gone to using more of these intramedullary ones because I think there's mechanically more sound. It also takes up a lot more space, so there's less likely to have to put graft in. But if it's in the neck, you probably want to put an allograft strut in there. Remember, fibrous dysplasia heals with fibrous dysplasia. Okay, osteofibrous dysplasia. These are the anterior tibial lesions, bowing lesions you see on kids. Usually asymptomatic, but they may have the saber shin or the prominent tibial bowing. Radiographically, it's multiloculated lesions, expansile the anterior cortex. Here's a common appearance to it radiographically. It's a kid I've been following for a number of years. Same thing, anterior cortex and involvement you can see on the MR. T1, T2 image. There's the T1 image kind of crawls along the anterior aspect of the tibia there. Another example of it, anterior involvement, occasionally shows up in other bones, but when you see it, you're going to see it in the tibia. Histologically, you get fibrous tissue, loose trabeculae, but you get rimming osteoblasts in this. Unlike fibrous dysplasia, here you do get rimming osteoblasts, and hence osteofibrous dysplasia. The treatment is observation until maturity, excited if it's symptomatic or progression, but frequently we don't have to do anything to these people. So here you go, immature trabeculae, but rimming osteoblasts. All those osteoblasts right there. Right, Parsons, you're on drugs. Trust me. Rimming osteoblasts. Abnormal woven bone. Paget's disease. Condition of abnormal bone remodeling presenting commonly in the 5th decade. 3 to 4% of the population by the 5th decade. By the 8th decade or so, you probably have 10 or 15% of the population involved. It can be monostotic or polyostotic. Typically, it's asymptomatic. Pain and subtle deformity is common, but the onset is very insidious. And radiographically, you get this lesion that sort of sweeps through the bone from one end to the other with this blade of grass, advanced edge appearance. There it is. There's the blade of grass. Angular because it's fibrous, and this advanced sweeping. When it's in its early phase, it's lytic. Then becomes mixed lytic and blastic, and then towards the end it becomes blastic. So there in bold letters are the 4 hallmarks radiographically. Coarse purposeful trabeculae, mixed lytic and blastic appearance, thickening of the cortex, and enlargement of the bone. Those are the 4 things you see radiographically. You should kind of remember as your buzzwords. You may see the osteoporosis circumscripta or the cotton wool exudates. I'll show you an example of that in a second. And remember, the etiology is thought maybe to be paramyxovirus. Inclusion bodies have been found in osteoclasts. So that's the buzzword there for the etiology, paramyxovirus. So here's cotton wool exudates here, and here's the circumscription there, osteoporosis circumscripta in the skull. Here's involvement, diffuse involvement of the bone. Here's the enlargement of the bone, picture frame vertebra, secondary to the Paget's. Here's the dense involvement here, mixed lytic and blastic. Bone is enlarged. When they fracture, they get these chalk-like fractures on the tension side of the bone. And here's another example of the thickening and the advancing flame of bone that marches down through the bone, one end to the other. Histologically, what do you see? A mixture of osteoclastic and osteoblastic activity. Remember, this is coupling gone awry. Resorption and formation is gone berserk. When Henry Mencken teaches at the instructional course lecture every year on Paget's disease, the example he gives is drawing the house. He says, if I draw it neatly, I can get all the detail in there. If I say faster, 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 pretty soon it doesn't even look like a house. I'm just scribbling something up there. Well, that's kind of the way this bone looks. It looks like scribbled bone. It's just all angulated together with different cement lines. There's also myelofibrosis and prominent vascularity. These patients bleed. When they fracture or if you operate them, they bleed like stink, and it's good to treat them preoperatively with bisphosphonates or calcitonin. I've got a few pearls in your Parsons pics you can look at. Here's the radiographic, or excuse me, the histologic appearance. Here's this mosaic appearance to the bone, prominent cement lines, lots of osteoclasts. Here we go on the saffron and O stain. You can see it polarized. You can see all the cement lines running every which way. Here's the same thing again, this mosaic pattern. Everybody knows what mosaic is, right? Little tiles put together kind of randomly to make a pattern. Well, bone isn't random. Bone is very well aligned unless it's pagetic bone. And here's the hallmark. Here's the hallmark. It's the osteoclasts and the blasts. Now, these people do not like each other, and they like to be segregated. The clasts hate the blasts, and the blasts hate the clasts, and they never are on the same trabecular unless it's pagetic bone, because you don't have resorption and formation. They don't like each other's neighborhood, I guess. You never have those two together unless it's pagetic bone. Paget sarcoma. Oh, let me ask this. Surgical treatment for severe deformity, fracture and arthritis, that begs the question. Most of the time we don't have to treat pagetic bone, but you got to pre-treat them with something to decrease the bleeding. And we usually put cemented prosthesis in them because of the bone is still remodeling. The press thing in there just tends to get loose. Paget sarcoma you may see, but when you see it, you're going to see it locally destructive lesion associated with pagetic bone. So here's an example. This is pagetic bone. Of course, for purposeful trabeculae, sort of enlarged, lytic blastic, and suddenly, oh my gosh, where is the tibia? All right? So this is destructive. This is pagetic bone. We're trying to show you that you've got a Paget sarcoma. Less than 1 to 15% transformation is reported, but this is the prognosis is death. You treat it like any other bone sarcoma, chemo, surgery, chemo, but they're older people, so you may not be able to give them chemo. Here's another example. Pagetic bone destruction. Pagetic bone destruction. Pagetic bone destruction. Pagetic bone, the destruction on the scan. Okay. We only have one little bit left of bone, and I'll let you stretch for a second, and we'll finish soft tissues, and we're going to be out of here in okay time. I know it's going fast. Sorry, there's a lot of stuff, guys. get this last one to open. So let your mind relax for a second. I heard a great joke from one of my military colleagues, probably about a year ago, but it's still pretty funny. This Marine goes to the White House. You know, they have the guard station at the White House. He's in dress uniform. And you know, Marines, you know, not like us Air Force guys, the Marines are sharp. They're always sharp. You can cut your hand on their crease in their trousers. These guys are stuck. I knew a Marine at the academy when I was a cadet. He was an AOC officer in charge of a cadet squadron. I kid you not, he brought 3 pairs of pants and 3 shirts to work every day. Why? Because when he sat down, he'd wrinkled the crease. So he wanted to put on a fresh pair of creased pants and shirt before lunch formation, before afternoon inspection, and before the evening formation. So that's it. Come on, man. I'm sorry. That's way too much. But anyway, this is the way Marines are. So this Marine goes to the guard station at the White House, knocks on the door, and the White House guard, of course, is not nearly as sharp. And the guy's like, opens the door, says, can I help you? He says, I'm here to see President Clinton. And the guy says, Clinton is not here, moron. He says, yes, sir. Thank you, sir. Salutes, turns away. The next day, he comes back, knocks on the door, and he says, I'm here to see President Clinton. And he said, didn't I see you yesterday? Can't you get through your skull? Clinton is not here. He goes, yes, sir. Salutes, goes away. Third day comes back. Same thing. And the guy says, look, how many times do I have to tell you? Clinton is not in the White House. It's Bush in the White House now. And the Marine grins and says, yes, sir. Just glad to hear it. Salutes, turns, walks away. All right. If you're a Democrat, don't shoot me, please. All right. Metastatic disease of bone. This is the most common bone lesion in older people. And the reason a radiologist will say met or myeloma is because, you know, myeloma involves multiple bones potentially in an older person, and so does metastatic disease. So that's the buzzword that they'll use, met or myeloma. Over age 40, you got to consider metastatic carcinoma for all lesions because, once again, it can look like anything. Pathologic fractures occur in almost a third of patients with METs. And these are the ones we look at, the osteophilic lesions, breast, prostate, thyroid, lung, and kidney. What bones are involved? Vertebral bodies, pelvis, ribs, proximal limb girdles, Batson's plexus, we all know about that, the veinless valvular system, the valveless venous system that allows free exchange of cells. Radiographically, you get mixed lytic to blastic, and the 30-60-90 rule is something I tell my residents. 30% of lung are blastic, 60% of breast is blastic, and 90% of prostate are blastic. So when you see a blastic lesion in a man, it's probably going to be prostate, and in a woman, breast. So here's a common example of blastic lesions throughout the bone. Here's diffuse involvement of the pelvis and the proximal femur on this side, also with an arthritic joint. Here is a common occurrence of the destructive lesions, and here's the cookie bites you see often in lungs, which involve just the cortex. Destructive lesion, I showed this before, renal cell here in the vertebral body, destructive lesion, or pathologic fracture. Anytime anybody has a pathologic fracture in the spine, an older person, you better work them up for met and myeloma. The lesions are typically focal, and as I showed, here's an example again of just a cortical lesion, lung. Lung is the one that just likes to have a cookie bite out of the cortex, and lung is a very bad actor. Once they show up with metastatic to the lung, they usually have less than 18 months to live. Mets distal to the elbow and the knee are lung or renal. If you got your choice between the two, pick lung. If lung's not on there, pick renal. And that's because those cells have access to the arterial tree. Histologically, it's the epithelial cells present in a fibrostroma, typically or often in a glandular pattern. And so here's lung, and here's renal. Notice that renal is a lot more destructive than lung. But once again, they both metastasize distally. Renal cell lesions bleed. I told you that before. Myelomas and thyroids also bleed, by the way. Thyroid and renal cells may also be cold on bone scan, just like myeloma is. So just because you get a screening bone scan, if you don't see it, that doesn't mean it's not there. Unknown primary lesions are likely GI, as we mentioned. And once again, renal cell lesions bleed. Here's an example of prostate again. This is lung distally. Look at this gal here. Metastatic thyroid. Ma'am, doesn't that bother you? Oh, I just thought it would go away. This is killing me. And carcinomatosis, multiple involvements you see on the bone scan. Bone scan is a good thing to get to see in multiple involvement. Here's a gal who broke her humerus driving her car. Did you have pain? No, but I have pain now, and I understand that. And you see here destruction here, soft tissue mass, and she's a long-time smoker. It was lung. And I think Dr. Sears, sitting in the audience, did this with me. This was a plating from Hades to put the cement in here to stabilize a bone, which is like butter in a long plate to stabilize it. Proximal femoral involvement. So proximal, you got to take out the femoral head and neck. See the involvement there. Proximal femoral involvement again, high stress areas, fixation with some cement. Same thing here. This guy had diffuse disease. You can see spots here, spot here, spot here, and had been told go home and die. It was horrible pain. We replaced his hip because he also had hip pain on examination. So we decided to do both, and was pretty happy afterwards. What's the reason for treating metastatic disease? Maintain skeletal integrity. Okay? Treat the impending pathologic fracture with internal fixation if you need it. Throw cement in there if you need to. Radiation. Do not forget to radiate them. Don't treat them and say, all right, Mr. Jones, that's $6,000. Thank you very much. Your humerus is fixed. And they go home, and they come back 6 weeks later, and they say, I've got this ache in my arm, and your plate is loose. It's fallen off. And you say, oh, Parsons told me to send them to the radiation oncology guys. I told you, don't forget. They've got to get radiation afterwards because you didn't cure the tumor. You just stabilize the skeleton. Some of them will get chemo. We use bisphosphonate to help to control the destruction of the bone. You guys learn that in the basic science stuff. What does bisphosphonates do? Prevents osteoclastic function, right? Prevents it from forming the ruffled board. Harrington's criteria is what we use. Greater than 50% cortical destruction, high risk subtrochanteric area, persistent pain after radiation or greater than 2.5 centimeter lesion. This is the classic stuff. But guess what? This is what you really need to know, Morell's criteria. This is what we use. And this is basically giving them a score of site, pain, lesion, and size, and whether it's small or big, and whether pain is present all the time with activity or what. If the score is 8 or greater, fix it. If it's 7 or less, you can probably just irradiate and watch it. So that's in there for your purposes. That's from Morell from Core of 89. Here's a distal femoral lesion, metastatic. With this lady was really sick on oxygen and everything else. We put this rod in there, and I said, there's no way it's going to just flop around. We put some cement in there, and even that, it started from the time we did this to her getting radiation. She still had more change in there. I'm not sure she's still alive. I'm not sure if we haven't seen her back recently. Another distal femoral lesion. This person got told, go home, it's okay. And, of course, when she comes back to see me, it's not okay. Because now she has this, and we have to do cement and rod. This was a while ago when we were still doing those short reverse rods. And here's what you see. You see glandular structures, epithelial-like cells. Now, trust me, bones don't sweat, they don't lactate, they don't secrete. So if this is there, it's a met, okay? It's easy as that. Again, glandular structures, it doesn't belong there, it's bad. And osteomyelitis is our last bony topic. Often can simulate primary neoplasms. It can occur in any age group. Remember, this is a round cell lesion as well. Pain, common. Systemic symptoms, if they present with systemic symptoms, it's pretty uncommon because usually the bone can wall this off. Radiographs are non-specific. It has sort of this washed-out round cell appearance, but it can a wide variety of presentation. Destruction formation in chronic forms, and the classic is minimal osteolysis with surrounding sclerosis. So here's an example of some changes in the midfoot. Here's an example of a clavicle infection. Here's a humeral infection. Here's a distal femoral infection. You can see it on the MRI. Remember that the sequestrum is the dead bone that's present in there. We don't typically see that. But the reactive bone around it is called the involucrum. So the reactive bone is the involucrum. That's not infected bone. The sequestrum is the dead bone that's there, and that has to come out. Here's a proximal tibial lesion. It's kind of diffuse in there. This is a guy that had known osteonecrosis of the proximal femur and comes in and he's got horrible pain, horrible pain. I said, this guy is crazy. Send him to the emergency room, send him away, comes back again, and he had an infection there. And so but finally, when he came back 3 times in the course of 3 or 4 days, I said, something's going on. and he had diffuse infection of the proximal femur that had broken into the joint and up by the acetabulum and all. Here's somebody who got sent to me a while back who'd had a fracture that was fixed, and when they took the hardware out, he said the pain doesn't go away, and he's got fevers, and the wound's not healing. Well, it's infected, and indeed, he had a syndesmosis screw, which is infected on this side, infected on the malleolar side, and so we washed out and put some cement in there. Destructive lesions at the end of the distal phalanx, proximal tibial plateau, and here's the chronic infected appearance that you see, long bone involvement. These are the kind of cases when we go to South America, third world countries, that you see diffuse involvement of the entire bone. Histologically, what do you see? Granulation tissue, vascularity, mixed cell population with polys, lymphs, plasma cells, and histiocytes. So these has the mixed cell population. That's what they're going to show you on the photomic with the X-ray. Chronic infection, remember, may present with squamous cell carcinoma, and of course we know about treatment, aggressive debridement and antibiotics. So here's what you see, the mixed round cell population with bone, mixed round cell population with bone, and this is what they're trying to show you. Mixed round cell population, all different cell types, including plasmas and lymphs, with bone. Osteomyelitis associated with TB shows washed out appearance, but if they're trying to show you tuberculous infection, you're going to see the sort of granulomatous appearance on plain film, on photomics. And there's been recently, as you guys know, in the OHEE, a resurgence of fungal type things. They'll show you an infection, a lytic lesion of some kind, and they want to see if you can recognize the Langhans cell, the multinucleated, and there's a spore in this one. Here's again, Langhans cell with the nuclei around the side with the associated spore. Spores, if you see spores, it's fungal. And typically they're going to show you a spore if they're trying to show you a fungal infection. Just remember, not everything that is worrisome, periosteal change, is bad. This is a stress fracture. And that's good. There's Henry Mencken in a manic mood ages ago when he was president of the Academy. Stand up and stretch while I pull the soft tissue stuff. I think we can still do this. Okay. I know this is a whirlwind. There's lots of stuff to get through. Once again, let me reiterate that if you will look over the Parsons pics, you're going to see the basics of what you need to know. And you've had site association now. It's going to click for you. I'm virtually certain that you guys are going to do great on the path portion. I've never had anyone tell me otherwise. Maybe they're all lining up and plotting to assassinate me or something. But I've never had anybody tell me that they didn't do well in the tumor section after coming to this course. Okay, let's keep going, because I know you guys want to get to dinner, and the sooner we get done here, the sooner we can go to dinner. I'm not going to take a lot of time in this first slide because we sort of talked about this before as classification. Soft tissue tumors are common lesions, but you got to exercise care because there's a lot of overlap between malignant and benign, and they're broadly classified as reactive, malignant, or benign, and by tissue type. You have to work them up with imaging, in particular MRI and bone scintigraphy. Many soft tissue sarcomas are painless and insidious in onset, classically synovial cell, so you got to maintain a high index of suspicion. We talked about that yesterday. Benign soft tissues occur in all age groups. They vary from asymptomatic to growing lesions, but they're usually smaller and more superficial, which goes along with the staging. Malignant lesions are typically enlarging, initially painless, but become painful masses. Most are larger than 5 centimeters and they're deep. Occasionally they can start off small and be present for years, and like the synovial cells, one of the classic ones, also clear cell and epithelioid. Most lesions require a combination of surgery and radiation. So fibrous lesions, we'll go through them really quickly. Calcifying aponeurotic fibroma, this is probably one that's not very commonly seen. It's on the hands and feet of young adults and children. It's dense fibrous tissue with calcification, cartilage formation. I don't think you're probably going to see this. These are treated with local excision, and they're benign, although they can come back. And you see dense fibrous tissue that's fairly benign in appearance right up underneath the dermis. Local excision, recurrences are common if you don't get it all, but you can take it out again, and they're benign, and they resolve with maturity. I wouldn't get too hung up on this one. Fibromatosis, plantar and palmar. This one you may very well see, but probably couched in a hand question. Nodules are painful early. Remember, you don't operate on painful nodules because they come back with a vengeance, and you get contractures with late stages and have to release them. The smart hand guys will tell you all about that. I'm just a dumb tumor surgeon. But this is what you see, and you have to dissect them out. You know that. In the plantar surface, they also get them. Peyronie's disease associated with the penis. Lederhosen's disease in the foot. And, of course, the Dupuytren's in the hand. And here's what you see. Dense fibrous tissue. Dense fibrous tissue. Benign, bland fibrous tissue. It looks like scar, and it's very difficult to tell from scar, which is why they're hard to get out. Fibromatosis, or extra-abdominal desmoid. Remember, this is the same as desmoplastic fibroma, but this is now in soft tissue. It's very invasive lesion, commonly in adolescents and young adults. It's firm, fixed, typically asymptomatic, and can be there for a long time, and they're common on the shoulder, chest, back, and thigh. When they're present near the bones, they can be erosive into the bones, like this one, hot on bone scan because the bone's being eroded into. Here's a big soft tissue lesion in the thigh, big soft tissue mass on cross-sectional anatomy, not hot on bone scan, and resected specimen. We want to get these with negative margins if we can. Recurrence is common in these things, unfortunately, up to 50%. Recurrent lesions, sometimes we watch them because they may spontaneously regress. We radiate them if we haven't been able to get them out completely, or if we don't think we can get them out completely. And the prognosis overall is pretty good. 5-year survival, about 90%. Death, when it occurs, is by local invasion. There's been a lot of interest recently in giving chemotherapy to these people, vinblastine and methotrexate for some of these lesions. I think your board answer is still, for a primary lesion, resect it. And if you can't get it out completely, resect it and irradiate it. If it comes back, if it's recurrent, and you're given the option to give them chemotherapy, that's what I'd pick. That's how I interpret the tea leaves right now. But primary would be resect it with a negative margin if you can, and if the margin's not clear, radiate it. Here's another example. Don't see much on plain film. Soft tissue mass here, soft tissue mass here. The signal is fairly low because it's pretty fibrous. Another one in the axilla, same thing. Bad place, low signal because of the fibrous appearance to it. And this is what you see histologically. This dense fibrous tissue, but this is the problem. It pushes its way through the muscle and kind of scatters, and so it's very, very difficult to know where the margins are. And histologically, you get this crinkled appearing spindle cells, collagenous appearance, scattered nuclei. This is classic appearance, but unfortunately, it looks fairly similar to scar. Nodular fasciitis is a benign fibrous proliferation. It's symptomatic, comes up quickly in young people. They're usually on the forearms, chest, sometimes on the back. And they're superficial lesions that we just take them out. This one's a fairly large one. Irregular fascicles of dense collagen. Sometimes mitotic figures are present. Treatment is marginal excision, and they rarely come back, so these are easy to treat. This is what you see with nodular fasciitis. A little more loose fibrous tissue as opposed to the desmoid, but fibrous nonetheless. Okay, see, that was quick. These are shorter chapters. We're going to get through them real quick. MFH. You're going to see an MFH. MFH and fibrosarcoma have similar clinical and radiographic presentations. As a matter of fact, as we go through all these soft tissue lesions, you're going to say, well, it looks like the last one, Dr. Parsons. That's because they kind of look like themselves. I mean, soft tissue sarcomas, there's not a lot we can do to say, hey, that's going to be an MFH, or that's going to be a synovial cell with a few clues that I'll indicate to you. But in general, they kind of appear the same. These are typically in older patients, 30 to 80, enlarging painless mass, but when they get big enough, they become symptomatic. The radiographs are often normal or show a soft tissue shadow if they're big enough. Nothing here on the radiograph. You see some blush from the flow, but a big old soft tissue mass here seen on axial CT and on this MR. Deep-seated inhomogeneous mass. Storiform cells, exactly like you saw on MFH of bone. And fibrosarcoma shows herringbone pattern, just like you saw on the fibrosarcoma bone. So it looks histologically exactly the same, it's just that it's in the soft tissue. Here's another example in the pelvis. A little warmth on the bone scan. This thing is nestled up here in the fossa, iliac fossa. Here's another one around the femur. Big old MFH, soft tissue mass on T2 and on T1. Here's one that in the soft tissue around a chronic implant. This is a gal that got opened up for hip pain, was going to do hip revision. The surgeon said, okay, did a big exposure, saw this, elected to take this thing out. Then he biopsied, did a frozen section. The frozen section came back while this was in here, and he said, oh, that's a bad thing. Put the prosthesis back in, sewed her up, and sent her to the tumor surgeon. Said, oh, that really sucks. Listen, if there's something abnormal going on when you do an operation, just take a little piece of it and quit. You don't get any brownie points for keeping it going, and then you contaminate everything, and then you send it to me, and I'm going to hunt you down. I'll find you. I promise I'll find you. And you know what I'm going to do? I'll give the patient back to you. All right? I mean, your worst nightmare. All right. And here's MFH. You know, storiform, pleomorphic, very ugly in appearance, big, ugly tumor cells here, and this you can't miss this, and this is the kind of picture you're going to see. Treatment is wide resection with radiation. We give sometimes preoperative radiation depending upon what your guys like to do, particularly if you don't think you can get it out completely. We definitely give it postoperatively for the margins. Prognosis is bad overall. 5 years at 50%. 5 years is 50%. Mets are present about a third of the time, and this is one that can metastasize via the lymph nodes about 10% of the time. The superficial lesions have a better prognosis. You know that. We talked about that staging yesterday. Here's another example of one I treated a few years ago in the arm that was crawling up into his axilla. Here's the histology, very ugly, and we did a 4-quarter amputation. The guy lived, did fine for 2 years, and then suddenly showed up with a chest full of Mets and died a few months later. DFSP, dermatofibrosarcoma protuberans, nodular cutaneous tumor, early to mid-adult life. It's intermediate grade lesion. They rarely metastasize, but they're progressive in their growth. This guy had that for a long time. I said, sir, why did you just leave that there? Well, I thought it would go away. So, well, okay. So we ended up doing kind of a buttocectomy on this guy. 40% of the lesions are on the upper or lower extremities. Here's one, superficial like this. They always kind of grow out in excrescence. Here's another one here, superficial. You can see dark on T1, bright on T2. Histologically, uniform fibroblasts. Again, that storiform pattern, minimal vascularity. And the treatment is wide resection. You want to get pretty good margins. Greater than 3 centimeters has less of a recurrence rate versus 2 centimeters or less with a 41% recurrence rate. So if I can't go widely around it, then I'll go less around it and give radiation associated with it, because you can sort of hit it tangentially and not contaminate a lot of tissue with the radiation. Mets are rare, and once again, consideration for adjuvant XRT if you're close to it. Here's one around the ankle. It's a classic appearance to it. Cut this bad boy off. In this case, we did brachytherapy, put a flap on it, and does fine. Here's what you see. Low power. There's the dermis. Here's this fibrous tissue underneath it. And at higher power, you have this dense, packed fibrous tissue, which is a little more cellular than the average bear, and hence DFSP, intermediate grade lesion. Fatty tumor lesions. You will see these things. Lipomas, there are a bunch of different kinds of lipomas that are listed here. Angiolipomas are painful. They're kind of hard to find, superficial tissue. Spindle cell and pleomorphic are more aggressive in appearance. You're mostly going to see intramuscular lipomas. Lipoblastomas show up in kids. We'll go through some examples. Liposarcoma has a wide variety, from well-differentiated to dedifferentiated and everything in between. Myxoid is the one that's most common. Probably the one that you'll see on your board exam would be a myxoid liposarcoma, because that's what most of us have examples of. Lipomas, of course, are mature fat. They're subcutaneous or intra or intermuscular. Long history of mass, slowly going. It's almost always painless. Radiographically, you see nothing except the density, or lack thereof, I should say, on the plain film. And MRI shows fat characteristics. So here you go. Here's the plain film. There's not much to see there, but you still see this density change here. Here's a CT scan. The density follows that of fat. CT scan, density follows that of fat. Lipoma. Here's another one. This one has some mineralization in it. They actually can mineralize. Rarely, but they do. When you see mineralization, you worry about synovial cell, but in this case, there's all this fat there, so you know it's a fatty lesion and not synovial cell. Mineralization in soft tissue. Benign things, here's what mineralizes. Malignant, here's what mineralizes. In particular, watch out for synovial cell and liposarcs. So watch out. I'll just add that in for your benefit. So lipomas, follows fat signal. Here's a little shadow in plain film. Fat signal, fat signal, fat signal, and all sequences. That's the clue. All sequences follows fat signal. Now, I have never figured out why the primary care doctors, if there's something wrong with a person's knee, with their hand, with their elbow, with their ankle, what's the first thing a primary care doctor does? MRI. It's killing me. MRI. I said, well, they've got a little fracture there. MRI. And yet, if they have a mass, what's the first thing they do? Get an X-ray and refer it. Hello? So you just expect it. When people send you these masses, they rarely have worked them up. But if they've got something wrong with their knee, they won't get an X-ray. They'll just get an MRI. So remember, you got to get MRIs of these soft tissue lesions. And in lipoma case, it's pretty simple. It follows fat. Fat signal follows, matches sub-Q. Treatment is observation. If there's no symptoms, then your diagnosis is certain. And the reason I say that is because sometimes they're big enough, you worry a little bit about them being low-grade liposarcomas. Marginal resection, if it's symptomatic or growing, it's very rare for them to recur. There are some variants which are more cellular that are up in the shoulder girdle. I would not worry about that for purposes of the boards. You just know that for yourself. And histology shows what? Benign adipocytes. So here it is, benign adipocytes, a little bit of vascularity in there, no real stroma to it. And here it is, benign old adipocytes that all of us have and hate. And they can be pretty good size. This is a gal, I was certain this was going to be a low-grade liposarcoma because look at all the striations in there, which actually is because it's an intramuscular lesion, but it was not. It was all benign fat. Same thing here, and this is resected, and there it is. Benign adipocytes, and there's some of the skeletal muscle that's in there. Okay? Intramuscular lipoma. Okay? See how fast these are going? We're doing great. Lipoblastomas. Now, kids don't get lipomas. Kiddies get lipoblastomas. And this is immature fat that doesn't follow fat signals. They may be symptomatic, but typically are not, except mama comes in and hounds you forever because Junior's got this lump there that won't go away, and you're not exactly sure what it is. You work it up, it doesn't follow fat, and you say, well, okay, we probably better take it out or biopsy it. And here's an example. Does not follow fat sequence in all images. Here again, not like fat, definitely not like fat. Fatty, but it's immature and has sort of this myxoid background associated with it. Kids don't get lipomas, they get lipoblastomas. Okay, liposarcomas. This is a very common soft tissue sarcoma. There's several subtypes. They can range from very low grade to very high grade. Images show this dense cellular lesion with stranding through it when they get big like this. And the higher grade lesions can metastasize. One of the places the board may ask you is where will these metastasize? It's unusual about them because we ask you unusual questions. To the retroperitoneum. So liposarcomas have that pernicious habit of metastasizing to the retroperitoneum. So remember that. Put that on your list of tricks. Here we go. Here's a lesion in the thigh that clearly is not following the fat signal. There's fat signal there. This is not fat signal, okay? So big lesion that it may have some fatty appearance to it, but doesn't follow fat signal. Here's a large one with stranding in it, and I was afraid, whoa, boy, okay? And this turned out to be a low-grade, well-differentiated liposarcoma. Large, intramuscular. Here it is, large, intramuscular. A lot of it does suppress like fat, but there's enough stranding, and it was large enough that it turned out to be a very well-differentiated, low-grade liposarcoma with some little more immature cells in there. There we go. More fibrous stromal background with adipocytes and there's atypical cells associated with it. So well-differentiated liposarcoma. Again, not fat density, not fat signal, soft tissue mass. Same thing. And they do metastasize. Liposarcomas are frankly malignant, particularly in the higher grades. And in the pleomorphics, you'll see this. If we show you an aggressive liposarcoma, the reason you'll know it's a liposarcoma on your board exam is because they're probably going to show you areas that have these adipocytes in it. See that? Is vacuole fat, but all this other looks more like a round cell lesion. That's how you're going to know it's a liposarc. Again, here's another large one of the thigh. Does not follow signal, mixed GAD, bright on T2, dark on T1, does not follow fat, is a liposarcoma. How do we treat them? Like all the others. Wide excision for intermediate to high-grade lesions. The prognosis is variable. Well differentiated, it's a very good prognosis. Pleomorphic, it's worse, 56% at 5 years. And just one word of caution, when people refer to atypical lipomas, an atypical lipoma, if it's superficial to the fascia, is just that. It's an atypical lipoma. It's probably okay to shell it out. Deep to the fascia, an atypical lipoma, if your pathologist calls it that, it's a well-differentiated liposarcoma, and you got to treat it as such. Just be aware of that. Remember, it does not follow fat signal. I'll get off my soapbox now, but everything that gets sent to you it's just a lipoma, and it's not. Here's one we took out of the thigh. Here's a sciatic nerve, biopsy tract there, big old soft tissue resection from this thigh. Treat them aggressively. And here's a well-differentiated one with cellular elements. Here's a myxoid liposarcoma. You can tell us, here's the fatty portion of it. We've got this myxoid background and cells. And these are pleomorphic, aggressive. But again, look, the fat, the giveaway that you'll see on the histology they're going to show you. This guy here, he just like walk around with a backpack, huh? I feel like I'm hiking, Dr. Parsons. So you think you have a monkey on your back? That's bad. Okay, neural tissues. Neurolemoma, benign schwannoma, which is the same thing, neurofibromas and neurofibrosarcomas. You're going to see one of these. Typically, neurolemoma is the one that more recently has gotten press, and so you've probably seen neurolemoma. Benign nerve-sheath lesions of young to middle-aged people. They're usually asymptomatic, usually on the flexor surfaces. If they're big enough, they may get compressive symptoms in the nerve. They usually will wax and wane in size because it has sort of cystic changes in it. The person will say, yeah, sometimes it seems bigger, sometimes it seems smaller. Now, when a patient tells you it's bigger and smaller, that's a classic description of hemangioma. That's the classic hemangioma description. So I'm not trying to confuse you, but these do give the same kind of thing because they have a cystic-like component to them occasionally. And the MRI shows a cystic eccentric mass associated with the nerve. Here's soft tissue mass. Here's a soft tissue shadow on there, nothing on plain film. And there it is. The nerve is stretched over this thing. You split the nerve open, you pull these things out. Sometimes the nerve looks like snot when you're done. I guess that would mean it makes it look myxoid, huh? No. It looks all beat up. But still, if you're careful and you peel this thing out, most of the time the nerve functions pretty well. Here's another example. Thigh, there's not much to see in the plain film. The lesions where the sciatic nerve should be, there it is. And they have this mixed signal on MRI. Here's an example we operated just recently around the proximal femur. Mixed signal on gadolinium. They usually have this sort of mixed because it's not all completely vascularized because of the myxoid component to it. And what do you see? Antony A and Antony B areas. Remember, Antony A is the compact spindle cells with nuclear palisading and verrucate bodies. I'll show you that in a minute. Antony B is the more haphazard, mixed, delicate collagen appearance. So here's A and here's B. Dense, fibrous, more loose, myxoid appearance. And here's the nuclear palisading. They line up like this, and this in and of itself is the verrucate body. So you get this crinkly background, and you get these verrucate bodies in here. This is what they're going to show you for neurolemoma. Treatment is removal of the mass, leave the nerve behind. The remaining nerve may be very tenuous, but leave it alone because it usually function. Recurrence is pretty rare. Even if you have to leave part of the neurolemoma behind, don't sacrifice the nerve. And the prognosis is excellent overall. And I expect this is the kind of thing you take out in your own practice if you're pretty certain of the diagnosis. So here's a lesion. Here's the sciatic nerve. Here's this thing expanding it. Here's the biopsy site, opening the nerve. There it is. Taking this bad. There it is taken out. There it is. And with a little wave of the hand, it looks great, doesn't it? So you can actually, in a nerve as big as sciatic nerve, get them out and they look okay. Sometimes it looks like spaghetti strings left in there and you just like, oh, I sure hope they'll do okay, but they generally do. Neurofibroma. These can be solitary or multiple. The lesions can be superficial or deep. They're slowly growing, typically painless except for late nerve symptoms. These are fusiform or bag of worms and cystic in appearance. Histology shows as wavy, crinkled, elongated cells of collagen. I'll show you that. It's a classic appearance. So also what you see is you may radiographically with a large neurofibroma see the scalloping from without. Scalloping from within is fibrous dysplasia. Scalloping from without is neurofibroma. Here's a big lesion where the nerve should be, same kind of thing. Here's some scalloping from without, lesion there, scalloping from without, lesion removed. Here's another larger lesion by the spine, here and here. Here's a large lesion in this gal's arm. And here's what you see. You see neural elements, and you see this crinkly, loose collagen tissue with spindle cells and the neural elements associated with it. So the treatment is marginal incision. The problem is that if it involves the whole nerve, which it frequently does, if you take it out, you're taking the nerve with it. So unless it's a nerve you want to sacrifice, like a peripheral nerve or cutaneous nerve, if you take it out, you may have chopped out their sciatic nerve, and then they are unhappy with you. Okay? So you may just tell them, look, we biopsy this. This is what it is. You got to live with it. Neurofibromatosis, you guys well know von Recklinghausen's disease, 1 in 3,000 live births. It's an autosomal dominant trait, but about half of them are spontaneous mutations, we think. Peripheral is type 1. Central forms is type 2. They have classically cafe au lait spots, skeletal abnormalities, scoliosis, NOFs, bowing, leash nodules in the eyes, axillary freckling. Don't forget to send them to the ophthalmologist. Malignant transformation occurs about 5% of the time. See how fast these are going? Let's see, we'll go to the next one here, which would be chapter 4. Close. Let's see, didn't we just do chapter 4? Did I have 2 of them open? Let's see. Maybe we're already on 5. The computer's getting slower. No, here they go. Okay, good. So the diffuse involvement, of course, for neurofibromatosis is the elephantiasis neuromatosum, the baggy, saggy skin, the so-called molluscum fibroma, the cutaneous lesions, and sebaceous cysts that they can get, so-called elephant man disease. Here's a patient we treated not too long ago who had neurofibromatosis and his big saggy skin, redundant neurofibromas within this thing. And you can see the image here. This is normal-looking thigh. This is back in his buttock over here. It's all that's involved in the T1, and it's brighter on the T2 images. This big saggy things. He did not like having this here. He wanted us to cut it off. Had to make sure that we're not taking away a sciatic nerve, which we ultimately did. The kid did fine. Here's axillary freckling present with neurofibromatosis. Here's a multiple cutaneous lesions. Another example of scalping from without. Neurofibrosarcoma is a rare malignant lesion, usually from neurofibromatosis patients, but you can get it de novo as well. Enlarging mass and pain, most are deeply seated. Histology is similar to fibrosarcoma, except it has some neural elements in it. And this is the glitch. It can spread for some considerable distance along the nerve, so they are really bad actors. So here's one in the axilla. They're very difficult to treat when there's this kind of location. Here's one in the posterior thigh. This has already been irradiated preoperatively. This person has axillary freckling, so you know they have neurofibromatosis. And here's resection associated with the sciatic nerve. And here's the specimen, sciatic nerve and the mass. Sometimes they will occur in very small nerves. Here's from the nerve root coming from the lumbar spine. And this one was picked up serendipitously because of pain. He was having nerve root symptoms worked up, neurofibrosarcoma, and this thing crawled up his nerve, all the way up into his cauda, all the way up into his cord. And ultimately, I think this guy elected to have his cord tied off and transected and make himself paraplegic surgically from the neurosurgeons rather than risk a recurrence. That's a tough decision to make. Say, okay, make me paraplegic. Neurofibrosarc, scalping from without. Here's a large one in the person with neurofibromatosis. Big soft tissue mass, and again, resected with a sciatic nerve. And here's what you see. Spindle cell, sort of fibrosarc kind of appearance, a little more crinkly than fibrosarcoma, and the elongated cigar-shaped nuclei. Once again, malignant appearing cells, spindle cells. If you see a neurofibrosarcoma on your test, it's going to be, trust me, associated with neurofibromatosis. That'll be how it's presented in conjunction with the nerve. Treatment is resection and radiation. You got to do a frozen section to make sure the nerve margin is clear because it may not, despite looking normal nerve grossly, and the prognosis is very bad. Why? Because they crawl along the nerves farther than you think. Overall survival at 5 years is 45%. Tumors of muscle. Leiomyosarcoma, small nodular lesions, usually are low-grade, deep-seated, high-grade sarcomas. They may or may not be associated with blood vessels because of smooth muscles there. Treatment is the same as other soft tissue sarcomas, and the prognosis is poor, like any deep-seated sarcoma. So here's an example, deep in the thigh, big soft tissue mass on MR, and resected specimen. This thing wraps around the femur, and there's no way to get it out without being aggressive. Another example down in the calf, soft tissue mass abuts the tibia and resected. This is what you see. Spindle cells loose with some vascularity to it, and malignant appearing spindle cells. And you have sort of these cigar-shaped nuclei that you see under oil or very high power. This is sort of the classic appearance to it. This is the kind of thing they should show you for leiomyosarcoma. Rhabdos, common in pediatrics, it's the most common soft tissue sarcoma in peds patients under 10. It's very malignant, but fortunately very chemosensitive. Alveolar subtype is most common in the extremities, and histology shows spindle cells, racket-shaped cells, and giant cells. So here's an example of a kitty with a soft tissue mass. You can see here on the imaging studies both coronal and axial images. And here's the embryonal rhabdo, and it has this sort of round cell appearance to it, pleomorphic. Let me take that back. I don't want to say pleomorphic because I don't want to confuse it with pleomorphic rhabdo. But it has this round cell appearance to it with this sort of the loose cytoplasm behind it. Here's another rhabdo I treated in a young guy up against his kidney. When I was taking this thing out, I had my hands wrapped around his spinal cord to protect the vessels. And I had my partner take the osteotomes and said, okay, strike these here and just go slow. Put the osteotome right in my finger. Cut open. I said, yeah, that's deep enough. It was painful. It was a pleomorphic rhabdo. Remember, 25% are pleomorphic rhabdo. You can see why I say pleomorphic. These look very, very diffuse. Here's embryonal rhabdo. Most of them are embryonal rhabdo because they're seen in the kids. And here's the cross striations, which they may show you on the high-power oil. It's associated with rhabdos. So rhabdos in a kid is probably embryonal. If it's an extremity of an adult, it's probably going to be alveolar. Treatment is the same as everything else. Chemotherapy, wide resection. Occasionally radiate them for inadequate resections. Overall survival rates are pretty good because they're so chemosensitive. See, we're burning along. Last couple, and then we'll look at some unknowns, and we'll let you go. Dr. Miller's back in the back. You're starting to pace. Vascular tumors. Hemangiomas, you will see hemangioma. Probably not hemangiopericytoma, but we're going to show you some examples anyway, just to recognize. These are benign. Hemangiomas are benign vascular lesions, common in adults and children. They can be anywhere, intramuscular, cutaneous, subcutaneous. Large lesions may ache and wax and wane in size. That's a common presentation clinically. And it's because they engorge with blood and then they disgorge with blood depending upon activity. The MRI shows a heterogeneous lesion with numerous small vessels. This is a common appearance like this. And often there will be fatty infiltration. So when you see an MRI on a T1, if there's fat in this thing, it's probably they're trying to show you a hemangioma. There'll be mineralization with it, and see how there's some, if the little flebal is, see how the change in the periosteum here sort of heaped up? We just published a paper at Scale Radiology this month, actually, about the juxtacortical changes with hemangiomas, and it's pretty common when they're close to the bone. Why? Bone knows one trick. Make bone. If the vascular lesion's next to it and it's ticking out the periosteum, it makes bone. And so you get this nice, smooth periosteal change. Here's an example down here, distal femur, kind of mixed wormy in appearance there. Here's an example on the MRI. Now, this is a kid we operated on pretty recently. T1, GAD, sort of cystic appearance, and T2, pretty cystic. Not much to see on plain films. They may be phleboliths. The treatment is basically observation, anti-inflammatories, vascular stocking, so on and so forth. If you take these things out surgically because you want to make a boat payment, it'll probably come back. The recurrence rate is pretty high, and it's because these things percolate out in the normal soft tissues. Recently, we've gained popularity with doing percutaneous sclerosing with alcohol, but it's very painful, and you have to give them general anesthetic. Again, we tried doing these things under local, and so I'm running out of the angiography suite saying, no, stop. And here's what you see. Here's a little bit of heaped up periosteal change, but look at the T1 image. There it is. Little bits of fat on the T1 image. Everybody see that? And on the T2, you see the bright sort of Wormian signal. So that's classic for hemangioma. There it is, juxtaposed to the bone. And this guy was sent to me and says he has a bone tumor. And I bet my chief last year, I said, no, he doesn't. He has a soft tissue tumor. And he bet me, and I won many sodas off this one. Same appearance, diffuse involvement in the bone, and you can see a little bit of mineralization on plain film. Here's another one, a little bit of mineralization. T1 image, aha, there's the fat again. GAD has a mixed hyperemia, and edematous on T2. In the arm, some changes. There it is. And here's what you see histologically. Muscle, typically, with a bunch of vessels. Looks just like in bone, except having bone there, you get with muscle and the vessels. Lots of lakes of blood, thick and thin-walled vessels permeate throughout it. Angiosarcoma is pretty rare. I won't spend a lot of time on this because I've not seen this on the board exam. But remember that you do get malignancies associated with these. Typically, there'll be cutaneous lesions like this associated with chronic edema or something going on. This guy had it here, multiple cutaneous lesions. Those are all angiosarcomas. You can see his leg and all this changes here in the periphery. Here's his normal side. This is a kid, excuse me, an older gentleman, not a kid, came in with this lesion in his toe, another angiosarcoma. They'd been there for a while that we amputated. And when they're near the bones, they can erode into the bone. So you may see something radiographically. And here's what you see. Vascular but malignant cells associated with the vascularity. I don't think I'd get too hung up about this. Synovial disorders, yes. This is one you will have to know. Ganglia, PVNS, giant cell tumor tendon sheath, cervicochondromatosis, and synovial sarcoma. In particular, synovial sarcoma is a favorite question on the boards. Ganglia, outpouching of synovial fluid from adjacent structure. We all know they're common around the wrist and foot. They have gelatinous mucoid material with them. Here's one around the nerve. Of course, they can compress the nerves, around the shoulder. They can compress the nerves up there in the spinal gland notch. Treatment is marginal excision, but you got to address the source. If it's coming from an arthritic joint or a problematic joint, you got to do something to make that joint better. If you just whack it off, it'll come back. And here it is, pure fluid on the imaging. And what you see is a little fibrous lining with this gelatinous tissue histologically. Here's when we treated around the foot. Same thing here. Bright on the tissue sequences. Don't see much on plain films. PVNS. This is another common lesion that you may very well see on your board exam. Reactive synovial proliferation, nodular or diffuse, most common in the hip or the knee, sometimes in the shoulder. Bloody effusion, and radiographically you get erosive changes on both sides of the joint. Not just one, but both sides of the joint. And it may actually erode into the bone pretty significantly. You may not see anything on plain films, but your MR studies show, for example, there's a nodular case rather than diffuse in the knee. This is what you see, this sort of red, shaggy appearance. Mankin calls it the red beard appearance. And here they can be erosive if they've been around long enough, and they're very destructive into the joint. They get arthritic symptoms because of the presence. Histologically, plump synovial cells, giant cells, hemosiderin, and inflammatory cells. There's a classic appearance of PVNS in the synovium. The treatment is complete excision and synovectomy. Unfortunately, we really can't do that very well, and so recurrence is a problem. Sometimes they'll burn out, but frequently these people have to have an arthroplasty because of the associated problems. Another example of the PVNF diffusely, long-standing, erosive into the tibia, fibula, and the femur. Histologically, here's what you see again. Here's another case here around the knee. You can see it in the back. You can see it in the front. Back here, the more diffuse case without erosive changes. Here's another nodular case. You can see that's filling up below the patella. When they're nodular like this, it's great because you can see it on your scope, and if it's small enough, you may be able to grab it and enlarge your portal and pull it out. But when they're diffuse, you got to open them up. And if it's front and back, my preference is to do medial and lateral incisions because you can get to the front end of the back as opposed to an anterior approach, which everybody does. All of you can do an anterior approach, but how many of you have done a posterior approach to the knee and done a synovectomy? It's not very easy. All right, there's one down there. It's not very easy. You end up with a kind of a tiny hole. And I tell you, can't tell me how many times I have someone sent to me, well, Dr. Parsons, I did the front part, but I couldn't quite get to the back, so I'll send it to you to do the back. Well, it's a separate stinking operation, and that's cheap. That's a low blow, below the belt. Okay? They get out in the front, send it to me, out the back. If you're not going to take it all out, don't do it. Send it to somebody else. They can be very diffuse. Look at this. This is a kid who had this around the proximal femur, recurrent, all around there, lower on T1 and T2 signal. You can see the bony changes around the hip. There's erosive changes around the knee. And here's what you see, this hemosiderin, this kind of hemorrhagic-looking synovium. Histologically, lots of hemosiderin, but synovial-like tissue and erosive changes. Another one around the hip. Large soft tissue mass in this one, way up into the pelvis, associated with the PVNS. Here's the clinical pearl. If you see something that involves both sides of the joints, blood, pus, pannus, PVNS, TB, and OA. It's going to be one of those 6 things. And you look like a champ as a visiting professor or on your rounds if you can spit that off. Giant cell tumor of tendon sheath, we've all treated these. You look histologically exactly like PVNS that are benign. Treatment is marginally excise them. Here it is down by the ankle, soft tissue swelling associated with them. They're pretty common in the hand. Here's one that's fairly extensive around the wrist. Again, you can take it off. And it looks just like PVNS. Some giant cells in it, synovial tissue. And that's the end of that. We're down to last one. And then we'll take a little review, and we'll be done. And it's 6:35. Synovial chondromatosis. This is a benign metaplasia of the synovium, and it forms these nodules inside the joints. You get all these marbles in the joints. People say, yeah, I get this fullness when I move my elbow or when I move my knee. And they can occasionally ossify and become synovial osteochondromatosis. Young adults, pain, stiffness, and swelling. Knee is the most common, hip, shoulder, elbow, just like PVNS. And you may see mineralized nodules on the plain films. Here's a great example of some grossly mineralized nodules, synovial osteochondromatosis. MRI shows joint full of nodular lesions. Treatment is excision, simple synovectomy, and occasionally they'll burn out with time. So you don't have to be quite as aggressive as PVNS. You're just going to get the stuff that you see. Here's an example around the knee. Here, this is synovial osteochondromatosis now because it looks like it has the bone signal in it, just like regular bone there. Here's another lesion here behind the knee. Someone said that this is parosteoblast. I don't think so, but you'd have to, when you look at that radiograph, you want to make sure it's not. And this is what you see. Chondroid tissue with synovium around it. Classic appearance, easy to catch. I think synovial cell sarcoma is about our last one. This is aggressive lesion, highly malignant, arises near, but typically not in the joint, although I just saw my first case of intra-articular synovial cell sarcoma in a 17-year-old who got treated by somebody who was mucking around in it, unfortunately, and now it's a problem for me to treat. It can be present for years, usually slowly growing. It may be around for a long time. It's the most common sarcoma of the lower extremities. Radiographs may show mineralization, so look for it. Remember, liposarcoma is another one that commonly mineralizes. So here's a gal who comes in to see me with this big soft tissue mass. You can see the blush on the bone scan. There's this big old lesion in your thigh with mineralization. Man, doesn't this thing bother you? Oh, no, it doesn't bother me. Well, it's killing me. What's going on? Just let this thing go forever. And clearly synovial cell with all this mineralization in it. Big soft tissue lesion in the axilla. Mineralization, extension all the way through the axilla. Histologically, they're typically biphasic, or they can be monophasic, but you're probably going to see a biphasic on the board because that's most easily recognized. Thigh and knee is the most common, followed by the foot. The treatment, like all of them, is wide resection and radiation. Unfortunately, late recurrence is a problem, and metastases is a problem. They can metastasize the lung and the lymph nodes about 20% of the time. So if your board question asks you whether soft tissue sarcomas are most likely to have lymph node spread or metastatic spread, pick synovial cell, because this is the one we commonly think about that metastasizes to the lymph nodes and will spread. Here's an example in a calf. There's a little bit of mineralization here in the plain film, right there. And CT scan shows mineralization density, soft tissue mass. The MRI, you see this thing back here. And biopsy site included, wide resection of it. Here's the case I was telling you about in this kid. It's inside the joint. Here's some very subtle changes radiographically, but here's the lesion here wrapping around the inferior portion of the neck of the femur, right up here, and right along the femur. This is all intra-articular in the synovial cell. Prognosis is poor. 5-year survival is 35 to 80%, but at 10 years drops way down. And it's probably because this lesion is underestimated or misdiagnosed. And it is frankly malignant. It can metastasize to the lungs. Here's what you see. Spindle cells and the epithelioid kind of appearance. This is the classic biphasic. More spindle cells, hyalinized spindle cells, and the more epithelioid appearance to it over here. Remember, bad things that calcify. We've already mentioned them. Miscellaneous sarcomas, epithelioid. This is common in the hand. It may metastasize the lymph node, much like synovial cell can. Histologically, polygonal cells with eosinophilic cytoplasm. This is often misdiagnosed, and wide resection of the radiation is how we treat them. So here's on the tip of the finger. People think they've got this granuloma. This is one I saw years ago. This guy persistent. Why did you let this go? Would you want to touch something with that? That's unbelievable. Anyway, epithelioid sarcoma, they'll typically show you at the hand, and you have to do a ray resection because those things are aggressive. And this is the appearance of the epithelioid sarcoma histologically. You get these hyalinized cords running through it, and these sort of epithelial cells all stuffed together with this pink cytoplasm. They sort of look like granulomas on the skin. So it's clear cell sarcoma, another one of these atypical ones. In your Parsons picks, I say there's usually one unusual soft tissue sarcoma. It's going to be one of these most likely. Nested fusiform cells with clear cytoplasm, and once again, wide resection and radiation. Here's an example of one in the arm, soft tissue mass there, up against the radius. And here it is resected, soft tissue mass there. Here's one around the elbow. And after resection exposure, that's exposure of the elbow. There's the Noive. And here's what you see. The clear cell, they have sort of this clear cytoplasm, lots of pink. It's less cuboidal than the epithelioid. Alveolar cell, slowly painless mass. Histologically, nests of rounded cells. Vascular invasion is prominent. And again, wide resection. And this is what you see. This alveolar. It looks glandular-like. That's why it's called alveolar. Okay, in general, overall survival with soft tissue sarcoma is about 50%, which varies on the grade and size of the tumor. Recurrence for low grade is low, and for high grade is high. No rocket science behind that. Met's about 20% in small lesions, about half the time in larger lesions. Local recurrence, remember, is at high risk for metastatic disease. Radiation therapy decreases local recurrence by about 30 to 50%, which is why we add adjuvant radiation. Chemotherapy is controversial. We like to give it in MAID and people that have high-grade lesions with maybe systemic involvement, but not all hem-onc docs will do that. And thoracotomy for pulmonary Mets is useful. If we can if you can berry pick them and get them out, you can increase their disease-free survival rate up to 40%. So we like to try to get them out. Okay. All right. Now don't go anywhere. Stand up and stretch. I'm going to show you some pearls for taking the exam. It's 20 of. We'll be out of here in about 10 minutes, and you'll have learned all the tumor you need to know. I know you guys are hanging in with me. I'm going to kill Mark for giving me these afternoon sessions. I'm getting the deer in the headlight look from you guys, I know. But you've been a really great audience. I appreciate it. And let's see. Core review slides right here. Okay. If you feel like you have to stand, that's okay, but just go to the back so the person behind you who's trying to sleep can see. So, exam tips and review cases. So, how do I pass this part of the exam? Stupid pathology questions anyway. I know how you guys are, because I walk around during the OITE, and when the pathology question is there, you always hear, ah, God. Okay? But after taking this course, you're going to say yes, because you're going to recognize the stuff, and it's going to be easy for you. Notice that MGH was by the jail. That's typically there. Okay, first, read the question carefully. Look for clues in the questions, such as anemia. Is it a marrow-packing disease or a chronic disease? Is there fever? Is it an infectious, inflammatory process? When you write the questions, the instructions to the authors are very specific. Don't put extraneous information in there. And when we write these things, we send them in, we get them back from the field test group, and they say, well, why did you put this in? Or why did you put it in there? And you say, ugh. So you try to put it narrowly. The information that's there is to help you, not to confuse you. Trust me. This is a picture. Mark Miller sent this picture to me from back in my academy days. And look at the short shorts and the tie socks in my much younger days. Okay, next, look at the imaging studies. Use the studies to guide you to a differential diagnosis. Remember the questions. Is it subchondral? Is it giant cell chondroblastoma? Is it diaphyseal? Is it a round cell or vascular? Is there mineralization? Remember the questions that Mankin and Nicking have. Ask yourselves those questions to go through the mental exercise of looking at the images and saying, okay, I see what's going on. Here's an example here of a gal who I did an internal hemipelvectomy on for chondrosarcoma. She is 9 years out now, has 2 kids, and doing great. Next, create a differential diagnosis based upon your question, the information in the question, and the imaging studies. Do not immediately rush to the histology and go, oh my gosh, oh my gosh. Try to create a differential in your mind first and let the pathology confirm your differential diagnosis. Put together a regional differential and you'll do fine. Here's Cosmos and Damien. You guys know the history of Cosmos and Damien? They were put to death by the Emperor Diocletian for being too religious or something. They came back a couple centuries later, and they had this parishioner who was dying, and they took off his leg, and they put on a Moor's leg on, so it's called the miracle of the black leg. So the first tumor surgery was clearly unsuccessful. The leg was black and didn't survive. Anyway, Cosmos was a surgeon, and Damien was an internist. And there's pictures of them in other places I've seen, and you can clearly see one is haggard looking and one is fresh. You know which one was the surgeon. Okay, finally, your differential diagnosis is made. Look at the histology. Use the histology to confirm your best choice on your differential list, and then make your best choice and stick with it. And don't go back and say, oh, no, I really meant what, no, I really meant was, just pick it and stay with it. Unless you get overwhelming information that it was wrong, such as the next question says, as you see, the last question was clearly fibrous dysplasia, then what would you do? So, oh yeah, fibrous dysplasia. But unless it says that, don't go back and change it, because most of the time you were right, okay? Most of the time you're right. Go with your first impression. As Springfield used to say, feel the force. Feel the force. And you'll most of the time get it right. This is a picture of me at my 20th reunion last year at the Academy. Okay, record your answer, move on. There's no time to transcribe answers later. Say, question 120 is B, 120 is B. Do that. Mark it and move on. And if you're uncertain, fold it. Answer it anyway and come back to it if you have time. But don't try to answer them all and come back and record them, because you'll be halfway through your test and the proctor will say 1 minute, and you just ought to just say, ah, and walk away. So, because there'll be no time. Okay. Just get your test on, as they say. I love that picture. Okay, review cases. We'll go through a few of these and we'll quit. Okay, young person comes to your office, pain in the knee, little change in the radiograph. Here's the MRI, soft tissue mass. The diagnosis is what? Osteosarc, right? Here's the pathology, abnormal cells. Clearly, here's the mineralization, this lacy osteoid that's becoming more than just a little bit lacy. Osteosarcoma. Okay, everybody gets that. Okay, pain, better with NSAID, this radiograph, this histology, cross-sectional anatomy is this, imaging is this. What's the diagnosis? Osteoid, you guys know that, osteoid, perfect. Okay, here is diffuse pain in an older person. Hem-onc doctor sends you down to see him because something funny looking on the radiograph has sort of this round cell appearance to it, clearly a round cell, diffusely involved in the bone. What do you think it's going to be? Lymphoma. Lymphoma. Why is that not myeloma? Because it's not monotonous. Those are not all plasmacytes in there. Okay? Okay, here, soft tissue, mineralization. We didn't talk about this, but I did talk about things that mineralize in soft tissue. This is benign now. Soft tissue mineralization, I'll just give you the answer. Soft tissue chondroma. Just remember that chondroid tissue mineralizes. Even in the soft tissue will mineralize. Okay? Okay, be careful now. Pain in the spine, older person, a little bit of constipation. These imaging studies show you clearly a soft tissue mass and changes in the vertebral body with this histology. It's a round cell lesion. Is it lymphoma? Is it Ewing's? Is it myeloma? Myeloma. Okay? Myeloma. These are the abundant cytoplasm, round cells through here. In the spine is pretty common. Okay? We didn't talk about this either, but you guys probably should know this. Ruggers spine, early minor flask. Good. Osteopetrosis, you guys know that, right? Sometimes we've got a hearing problem and all. Okay. Here's another one. Same person, multiple bony involvement, this histology, woven, or rather sort of mosaic bone with lots of blasts here, class over here. Its diagnosis is Paget's disease. Good. Okay? Soft tissue mass, been there a long time. These imaging studies, T1, T2, with this pathology. What's the diagnosis? Lipoma, right? Good. Lipoma. Soft tissue mass, getting bigger. This imaging, here's a T2, here's a GAD. This pathology, your diagnosis is liposarcoma. Good. Excellent. Okay. Big soft tissue mass in the thigh. This lady was killing me. She really was. Oh, but doctor, I thought it would go away. It's not going away until I took it away. Big soft tissue mass, inhomogeneous, This is a GAD study now, which means there's necrosis in there. Here's some hyperemia around there. This very ugly looking appearance, the diagnosis is probably MFH. Good. Okay, young person, diaphyseal lesion, this pathology, this plain film. Diagnosis is Ewing's. Oh, you guys are champs. Okay, what's this? We didn't talk about this, but this is some of the basic science stuff. Gracile bones, they get mineralization in the soft tissue. What is it? Osteogenesis imperfecta, OI. Remember the collagen disorder and basic science stuff? It's one of those ant minis. Here we go. Waxes and wanes, T1 image, a little fat on the T1 image, T2 and GAD with this histology. What's the diagnosis? Hemangioma. Soft tissue mass, painful, with this histology. What's the diagnosis? Remember I told you it can also occur in the pelvis or sacrum. This, what are these? Okay, giant cells. You're all saying giant cells. Good. That's exactly what it is. Okay, another site recognition. What's this and what's this? Osteoporosis and meliostosis. We observe those. Okay. Here, expansile lesion, GAD study, inhomogeneous with this pathology, expansile mineralization. What's the diagnosis? Chondrosarcoma. Chondrosarcoma. Good. Okay, soft tissue lesion, posterior thigh, right back here where the nerve should be, with this nuclear palisading. What's the diagnosis? Neurolymoma. Good. Distal radius lesion, subchondral, with this image and this pathology. Diagnosis is giant cell tumor. Okay. Be careful on this one now. Posterior pelvic lesion, CT shows destructive. There's a little bit of a soft tissue mass, brought in T2. Here's the pathology. Here's the bone scan. What's the diagnosis? Use all your clues here. This is exactly the kind of thing I'm telling you. Use all your clues. What's the diagnosis? Is it good or bad? It's bad. Right. This is very ugly looking. Okay. Looks like it's forming some bone in there. What's the diagnosis? Osteosarcoma. And what? Oh, notice this bone scan. What's missing here? I'm serious. Use all the information you have. Had an amputation of a prior malignancy and she's got a met. Okay, you're killing me. All right, what's this? This is a no-brainer. It's not fibrous dysplasia, it's paraosteal. Good. Okay, older person, proximal humeral pain, hot on bone scan. This appearance on biopsy, met. Oh, shoot, my arrows didn't show up in this thing. The computer gooned me. Anyway, soft tissue density here, broken out, metastatic. Remember, this sort of glandular epithelial sort of appearance. Okay, young kid, this washed out appearance, this histology. Don't get any more information. What is it? What am I showing here? Rosettes. Right, young person is going to be what? Neuroblastoma, right? Right, pseudo-rosettes and Ewing's, true rosettes and neuroblastoma. Okay? And if they showed you an abdomen, abdominal CT scan or something, you see a big mass in the abdomen. That's the other thing they'll show you. Or just a bone scan, and you'll see a spot in the abdomen from the bone scan to let you know that the primary lesion is there, okay? Neuroblastoma. Okay, here's a tougher one. Soft tissue mass around the hip has sort of this epithelioid appearance to it in spots, and other spots where it's more fibrous. So soft tissue mass in the thigh. Your choices are fibrosarcoma, MFH, synovial sarcoma, epithelioid sarcoma. What are you going to take? Synovial cell, that's right. That's what it's telling me. That's good. Distal femoral lesion, well circumscribed, CT scan, giant cells on, with a bunch of fibrous tissue. Serendipitous find. What is this? Giant cell tumor, no. This is a benign lesion. It's a NOF. Okay? Pain around the hip, brought on T2, soft tissue mass, hot on bone scan, destructive, this pathology. What's the diagnosis? Chondrosarcoma. Good. Distal femoral lesion, mineralized with this biopsy. Diagnosis is enchondroma. Good. Proximal tibial lesion, this biopsy, this finding, what is it? OCE. Excellent. Careful now. Nothing on the plain film. Intra-articular pathology. What is this? With this finding, hemosiderin. PVNS. Excellent. Proximal femur. This biopsy, what is it? Fibrous dysplasia. Proximal humerus. Down the canal. Hot on bone scan. Soft tissue extension. This biopsy, what is it? Osteosarcoma. This is very bad. Proximal tibial lesion, cross the physis, cobblestone appearance, soft tissue mass, what is it? Chondroblastoma. Proximal humeral lesion, this pathology, hemosiderin, what is it? Simple cyst. Proximal femoral lesion, fluid levels, this histology, what is it? ABC. Good. What's this? Eccentric with this pathology. Giant cells, myxoid. What is it? CMF. You guys are champs. Distal femoral soft tissue, posterior distal femoral soft tissue lesion with this histology. What is it? This looks like chondroid, right? So it's chondromatosis. All right. You guys are going to do great. Review your Parsons picks. You've been an outstanding audience. Thank you so much. I know it's a long day. Good luck to you.